Good morning once again. We will be starting the second thing, the result. So 8:40, I will start. I've already introduced myself. I'm Dr. Obstetrician. I'm based in Zimbabwe. The two big central hospitals at Mugabe and Park Hospital. I want to duplicate my screen. Okay, right. I think it's about time we start now. So we start with the talk on ultrasound assessment of the placenta. Ultrasound assessment of the placenta is something that is considered very basic whenever we are doing ultrasound examination. So I'm going to go to basic assessment to highlight some of the placental lesions that we may encounter, and I will discuss briefly some of the contexts that may lead to more detailed assessment of the placenta. To just share with you our experience of the placenta, to say the basic stuff assessment of the placenta. From 19, we noted that about 50% of the placenta, we do not deny that we are a high risk unit that see a lot of fetal growth retarded babies. But this data led me to think that we need to revise our grading of the placenta and also our ultrasound assessment. As one of my colleagues will show about the grading of the placenta, and these were the placenta position. The most common is placenta positions were actually anterior in about 50% of the cases, and followed by posterior, but only about 1% of our placentas were placenta previa. Vasa previa is maybe 0%. It's not to say there was none, but vasa previa. And we also have got the posterior lobe and the anterior lobe placentas. The reason why the anterior and posterior lobe are not that high is because from our data, most of the second and third trimester, we have very few first trimester onto a low placenta. So whenever we are assessing the placenta, what is it we want in basic assessment? We always want to know the position, the appearance, the placenta function, not really function, but sort of, yeah, gross assessment of function using Dopplers. A pathology that we may see on the placenta, so the relationship with us. Method assist can be both transvaginal, depending on the circumstances. Of course, if you do have a fetal placenta and the second, third trimester, there is no need for you to say you want to get assessment to check the placenta. But if you have a placenta which is on the low-lying part, or where you are not sure whether it's extending all the way to the internal also or no, you may need to do transvaginal, because that has an obstetric implication. Placenta positions, very easy, as you can see from what we illustrated here from our illustration, that this is an anterior placenta, very easy to locate. Most amniotic fluid is, and we are having a second trimester, third trimester baby, or even first trimester. First trimester may come into inexperienced health, but generally, placenta location in the presence of amniotic fluid, if it is posterior, it should be easy again. So that's a posterior placenta, as you can see demonstrated. This is just the position. I did not put the other position, the lateral or the fundal and so forth. However, when you are looking at my image, it's never easy to say, is it truly like this one? You may not be able to say, is it really an anterior placenta, posterior placenta or not? Because it depends on where my probe is and so forth. It could be a placenta which is probably lateral posterior or so forth. But I'm saying posterior because I did the scan and I know where the placenta was. But the placenta is at the back in this case. The placenta position, the placenta could be low lying. When we are saying it's low lying, we are saying it's less than 2 centimeters from the internal os, as is demonstrated by our image here. We highly recommend that whenever you think that the placenta is low lying, you should check transvaginally. Note that most centers in Africa probably do not do transvaginal assessment, but that is what we recommend. We highly recommend that if you're in placenta assessment and you think it is low lying, do it transvaginally, as is demonstrated on our image here. So I'll give myself a pointer here to just make it easier. So you can see this is the cervix here, and that's the cervix, and this is this yellow tracing there, this orange tracing, and this is the distance from the internal os, which is 17 millimeters. So in this case, a low-lying placenta. Low-lying placenta need to be followed up enough to allow for vaginal delivery. And this is a case of placenta previa. We can see that the internal os, the placenta is touching on the internal os, and this is the cervical canal here and the cervix. So yeah, again, we highly recommend that if you suspect that it's on the low lying side, do it transvaginally so that you can be sure that indeed it is low lying. If you don't do it transvaginally, sometimes you may overdiagnose low lying placentas in cases, because most people who do transabdominal scans, they do it with full blood. The compression of the gas make the placenta appear like it's actually low lying or even a placenta previa when it is not. So the advantage of the transvaginal scan is that we ask the women to empty their bladders. So we take care of the problem of the isthmus. However, in certain cases, you also have to be aware of the consistency of the cervix itself, the cervical tissue on ultrasound, so that if there is a contraction, because a contraction may mimic, like in this case, if there is a contraction of the isthmic portion of the uterus, this placenta may look like there is a previa when there is none. So this is very important. Just want to clarify again the placenta position. I think when you read our old obstetric books, you may know that there was this classification which says the placenta is low-lying, marginal placenta, partial placenta previa, and then major placenta previa. But I want to make it clear that the placenta is either high, it's a high placenta, or it's a low-lying placenta, or it's a placenta previa. The fact that it's touching or covering the os clinically doesn't change how we manage this placenta. As long as the placenta is touching the os, is placenta previa. Of course, in our reports, we mention by how much it is extending the other side of the uterus. If the placenta is posterior, we normally mention how much it is extending to the anterior part of the uterus. The reason for mentioning that is not to try and grade, but what we are trying to say, to emphasize that we do not, this is a placenta we don't expect to move or to change much, to the extent that people may think that the placenta is migrated enough to allow for vaginal delivery. So the point, again, to illustrate from this diagram, to say the internal os in a closed cervix is a point. So naturally, there is no way you can say you are the placenta. This is just to illustrate, to say this grading was being done by people who were passing a speculum and shining some light on membranes which are still intact. That's how this grading came about. In the advent of ultrasound, where we are able to do ultrasound, we are not going to be diagnosing this kind of placentas, but you are going to diagnose them while the internal os is still closed. This is what I want to clarify concerning the old versus new classification. Part of the placenta assessment is the code insertion. The code has to be assessed in terms of where it is inserted. It will be inserted central, which is ideal, which is the good part, where the code is inserted central, or you could have a marginal code insertion, or you could have a filamentous code insertion. All these insertions have an obstetric implication. In a marginal insertion, like in this scenario, this was a case of a bilobe placenta. You can see the other part of the placenta at the top there, and you can see the cord vessels going over to the other part. The cord was actually inserted on the posterior lobe of the placenta. So the implications are these: in that if it is central, this dichotomous branching of the chronic vessels is so that if it is peripherally inserted, attenuation that happens will mean that this chorionic plate here will end up being poorly vascularized. And in their paper, in this paper, they noted that this may cause a 10% discrepancy in the birth weight for babies who have a central and eccentric or marginal code insertion. So placenta code insertion has to be assessed. We do it routinely, but I know most guidelines on ultrasound do not probably mention that we should be checking for code insertion. The other importance of doing code insertion is that if it is filamentous, that means it's attached on the membrane. This has an obstetric implication, because one of the obstetric practices at delivery is to do code traction. Doing code traction on a filamentous cord insertion may lead to rupture of that cord and the woman bleeding while the placenta is still inside. So it has potential to cause postpartum hemorrhage if you miss that the placenta is inserted this way. It just has the same as picking up a bilobe placenta. If you miss a bilobe placenta, people will deliver one lobe and walk away, and the woman will continue to bleed. And probably it is only at post-mortem that people know that there was another lobe of the placenta. Those kind of scenarios do happen in our regions here. And to just summarize and say, you are looking at the placenta, which conditions may cause them to go a little bit digital placenta. They're doing well. Of course, the placenta has to be evaluated. And when you are evaluating the placenta, what is it that you have to look at? First of all, the placenta itself, the span of the placenta has to be assessed subjectively. There is a nomogram which I will show you, which has been proposed for second trimester placenta assessment. But you have to subjectively look at the length of the placenta to say that normal placenta, its longest span normally should not fit within the scanning range, the field of view in third trimester. But if you see a placenta where you nicely, this is not a second trimester, it's a second trimester placenta. So if you can see the whole span of the placenta in its longest span, then definitely you need to think and say, am I looking at a small placenta or not? And we also have to look at the retroplacenta space, which should be very clear. it's easier to visualize the retroplacenta space for a posterior placenta. For an anterior placenta, to visualize the retroplacenta space, do not apply the pressure. If you apply the pressure on the abdomen with the probe, you are going to obliterate the retroplacenta space with the pressure you are putting. So for the retroplacenta space, make sure it's easier. Pressure is not going to affect this, so it should be very clear without any hematoma or any lesions in it. It should be anechoic, this retroplacenta space, to rule out retroplacenta bleeding. The placenta thickness should be measured. Ideally, should be less than 4 millimeters. But again, like I said, there are nomograms. Some books saying, that's what the American, the ACOG, the same in third trimester should be less than 6 millimeters. So in our unit, we use 4 millimeters as a standard to say if you measure the placenta is more than 4 millimeters, the placenta is abnormally thick. Appearance, it should have homogeneous echogenicity. My image on the screen there, it's more echogenic than it should be. I think it's the settings. This was a normal placenta. It was not an echogenic placenta like what is being shown on my image there. So this is these are the nomograms of the placenta thickness and also the curvilinear length, the one I was demonstrating. If you do your length here in second trimester between 20 and 22 weeks, you do your length and you see that it's falling outside, then you can make your conclusion. You say the placenta is looking abnormally thick or it's too thin a placenta. So this is the nomograms. You can look at it later. These videos will be available on YouTube. Then just to demonstrate a thick placenta here, placentomegaly, and also this is just another preview. You can see the cervix, internal os, the placenta fully seated on it. Then we can see placenta legs here. The placenta legs, if they are less than 40%, they have not been shown to affect growth. Our approach with the placenta legs is to offer these women fetal growth surveillance. So we've been bringing these women for fetal growth assessment whenever we see numerous placenta legs. But if the placenta legs are scanty, there is no reason to really monitor them. So far, even those with significant amount of placenta legs have gone on to have normal normal birth weights, baby birth weights, the ones we have followed up. So it looks like it's in a fairly innocent condition, the placenta legs. But I will differentiate from another condition which I'll present just now. Then we can also have some hematoma happening in the subchorionic space, what is called Breuer small later, where there's bleeding, that's subchorionic. You can see the normal placenta tissue just behind it there. Then we have patients, calcific two kinds of types. We have the basoplate calcifications here, which normally come as a result of placenta maturation, calcification deposits at the level of the basal membrane. Normally, this kind of calcifications, if the growth is normal, there's no need to do much because it's part of placenta aging in late trimester. However, you may also see these diffuse calcifications like we see on this placenta. If we see these diffuse calcifications, they may be need for us to investigate if a touch screen brought the possibility of touch calcifications, little lots of calcifications on the placenta. There is my colleague who will talk about infection. Then we can also have some lesions called intravenous thrombus, where there is an echogenic rim around an epic area here. These are intravenous thrombus. Again, these are abnormal placenta alterations, which have to be interpreted in the context of whether the baby is growing well or not. Because you will be trying to get the answer to say why is the baby not growing well, especially in the case where the uterine artery, the umbilical Dopplers are normal. And we also have got some placental lesions, the very small, which I mentioned, which is a subchorionic plate bleed. You can see that's a huge clot there, and this is normal placenta tissue. Whenever you see this, you also obviously have to monitor growth to see how this is going to affect the fetus growth. The baby has to be monitored closely. Then we have placenta infarcts. These are small white lesions. You you see there, these are infants. You can also see them here. Again, you have to correlate with how the baby is growing. If the baby is well, all you have to do is to monitor. It's not growing. Probably this may explain why, and we may need to assess other parameters, the Dopplers and so forth. Lesion. Then we have corollary regression. We're talking about measuring the placenta size subjectively. You can see that this is the trimester placenta, which is spanning a very small distance here, and it's abnormally thick. So corollary regression is an abnormal formation of the placenta where there's a reduced number of villi, and also reduced number of villi here, and the placenta becomes abnormally thick, and there is engorgement of the intervillar space. So on ultrasound, the placenta becomes very small because the engorged blood in the intervillar space will escape a delivery. So this will be a small thin placenta, which on ultrasound we will see a placenta which looks big and spanning a narrow distance. Normally, for this condition, the uterinatal Dopplers are normal. So if you see an abnormally thick placenta, which is spanning a very short distance, you're more likely dealing with, of course, you also go other causes of syndrome. Then you've got chronic placenta abruption. You can see this bleeds just in the retroplacental space there. Yeah, then we also got some intra-placenta bleeds, as you can see here again. All these lesions which I'm showing you, you have to interpret them in the context of the baby's growth. If the baby is growing well, you monitor. If the baby is not growing well, you want to investigate further and to closely monitor, see the effects these lesions have on the baby's well-being. Okay, the placenta function can be assessed by doing uterinatal Dopplers. Where we measure uterinatal Dopplers, we can also predict future function of the placenta. If we do first trimester uterinatal Dopplers as part of screening for preeclampsia, and we can also be able to do etiological triage when you are having a small baby who is not growing well and you are wondering what is it because baby not to grow. If we do uterinatal Dopplers and they are that placenta vessels. Thank you so much. This is the end of my presentation. Without wasting much time, I will hand over time to the next presenter, Dr. Zambuko. While he's doing his preparation, let me introduce Dr. Zambuko. He's histopathologist based here in Zimbabwe with extensive experience in surgical anatomic pathology, and he has worked as a consultant now for several years now. He has served at all the 4 central hospitals in this country. He's worked before in Bulawayo at service UBH and Pilo, and is now based in Harare. He's a medical educator. He has held position as chair of pathology at the National University of Science and Technology and director of pathology postgraduate training at the University of Botswana. He's the current president of the Association of Pathologists of Zimbabwe and has varied research interests spanning in cardiac, HIV, pathology, and cancer in women. He spends most of his time doing surgical pathology at Lancet Laboratory here in Zimbabwe, and also teaching med histopathologists to registrars. We are hoping that Dr. Zaranyika will become our fetal pathologist here in Zimbabwe. We want him to hope this meeting will help him develop interest in doing fetal pathology. So without wasting much time, ladies and gentlemen, let me ask Dr. Zambuko to come through.
Good morning. Thank you for the invitation, Dr. Herenga. Um, I'm glad to be here. And like you said, we are hoping that we can develop a relationship going forward with pathology and fetal medicine. So I'm going to give you a very brief. I'm going to give you a very brief overview of the pathologist and the placenta. Of course, there's a caveat. We don't have fetal pathologists fetal pathologists in the country, but certainly we are generalists who see quite a bit of placental pathology, surgical pathology, and also in the morgue, we do perform autopsies on a number of maternal deaths, and we look at the fetus at placenta. So just as a quick introduction, we recognize as pathologists that examination of the placenta is underutilized, which is unfortunate because the specimen is readily available and the cost is not that bad actually. It's a reasonable cost. There are a number of benefits. I think we'll talk about those just now. But I think one of the most is that you're able to manage your property, you are high risk for some, but also it's a very useful sort of technique for audit and as well as medical legal resolving medical legal issues. And of course, research is something that is critical. Pathology is something that's in most spheres of medicine. So from our perspective as pathologists, the placentas you should send, or rather you should not send all placentas because that is implications on the cost. It's potentially financially disastrous for most institutions. But there are guidelines, guidelines developed by the College of American Pathologists, newer guidelines developed by the Royal College of Pathologists. So the newer guidelines are stricter, and perhaps I thought we should stick for now in our country because then that would limit the number of placentas we send in. The CAP guidelines result in a much higher proportion of placentas being sent for histopathological examination. But like I've already said, cost might be prohibitive. So what would make a pathology report, placental pathology report useful? I think if it can explain clinical symptoms and the fetal outcome, and perhaps assist in prevention of same condition in subsequent pregnancies, then it is done its job. Essential features are clearly defined diagnosis, evaluation of extent and severity, and even an estimation of future risk. What we're trying to prevent now is, or rather to minimize now, is having long lists of diagnoses, some of which can actually be misunderstood by non-specialists, fetal medicine colleagues, etc. And timeliness is important, and I'll touch on that as well just a little bit. And again, like Dr. Verenga said, really what we're looking at is an interdisciplinary sort of approach to fetal medicine. And I think placental pathology is one of those areas which really illustrates of it. We depend quite a lot on the clinical data that you put through, and when see specialist. And to address some of this, China workshop was convened in Amsterdam around September 2014, which was multidisciplinary, included fetal medicine specialists, pathologists, etc. And they agreed rather, I wasn't there, modeling criteria, immunology, and diagnostic criteria, etc. And the aim really was to standardize dietary and pathology. And I'll talk about those a little bit. I will not discuss the detailed anatomy and histology of the placenta because we wouldn't have enough time. But this is a pictorial cartoon just illustrating the basic um, anatomy of the placenta as we see it, or from our perspective as pathology. Right, so the placenta workshop group really emphasized that there is need for recommendation. That is to say, what we see on the placenta when it comes to that is critical. In fact, might be the only diagnostic there. Then, of course, microscopy is what we do best, and always try to detail that. But the most important section is the diagnostic section, actually, which provides unambiguous and clearly defined diagnosis. And then we often have a comment section where we correlate what we've seen and whatever information has been made available to us and try to discuss the pathophysiology. So I'll briefly run through these because they're pretty basic. But we often find that the clinical history is idiosyncratic, and it really depends on who's making the request. Some of it is complete and quite detailed, and some of it is just placenta, and the gestational age is not even stated. And that has implications, as you might imagine, on assessment in the proper clinical context. Right, the microscopic description, the placenta should be sent fresh. So we want to see it before it is being fixed, formal and fixative. And if need be, we can then obtain tissue for microbiology, cytogenetics, or some other molecular karyotyping processes. Of course, it's important not to include decidual maternal tissue because it will contaminate the specimen. And why I'm saying this is that the placenta should be assessed in both in the fresh and fixed states because some lesions are better seen fresh and some lesions can only be really characterized when the placenta is fully fixed in an adequate amount of formalin. So for the fixation, you need to immerse your placenta in approximately 10 times the volume of the placenta itself, 10 to 20 times the volume. There is a very wide range of parameters that we look at. Very wide range of parameters that we look at. We look at the membranes for color and translucency. We look at the insertion of the membranes. Are they abnormalities like circummargination or circumvallation? Obviously, try to measure the umbilical cord, but we don't often receive the whole umbilical cord. So that's not a very useful metric most times. We also want to look at the cord insertion, whether it's marginal or central, and for various other things like the coiling index, etc. We'll go on to then trim the membrane off and weigh the disc, look for check for completeness of the basal plate, and then section the placental disc parenchyma at maximum 1 centimeter intervals. And this will allow for a close or detailed inspection of the entire parenchyma of the placenta. And then, of course, we want to look at the maternal surface as well for evidence of retroplacental hemorrhage. We don't always see this, and we depend on the clinician to actually indicate that there was a retroplacental clot. But if we do get it, we measure it or weigh it. And then, of course, we need to sample it, and we need to take at least 4 blocks to adequately sample the cord, the membranes, and the parenchyma, minimum of 4 blocks. Then any other lesions are then sampled in additional blocks. So I think on average, you have 8 to 10 blocks that we submit for sample. microscopic examination for most placentas. But of course, if there's a significant pathology, the number goes up quite a bit. So it's pretty, from that long list I've just gone through for microscopy, it's easy to appreciate that you can miss out certain aspects of your gross or macroscopic inspection. So you actually need to have some sort of tool which allows you to be as complete or as thorough as possible. So we tend to use these pro forma or synoptic reports. So that lists all the items that you need to take. That makes it much easier departments of the plastic, and it the process or the time spent between receiving this one is sort of easy and all the detection. Okay, my apologies. The network is a bit unstable. As I was saying, I just trying to illustrate the process. So this tissue processing is really the step which takes the most time. We need about 14 to 16 hours. So essentially that's overnight. And then the subsequent steps, embedding, microtomy, etc., take another full day, I suppose. So really the minimum time is something like 72 hours, but it may be longer depending on load coming through to that particular lab. And in any case, placentas are not considered specimens by most labs, so they are sort of triaged into less urgent batch. Okay, so the next aspect of the report is really the microscopic, and it really depends on the institution. Some want to do a detailed prose. Some just indicate that with a little note that the sections have been examined and the diagnostic features are consistent with A, B. And traditionally, some labs have really emphasized completeness, but the question was always, is there standardization and what is the clinical relevance of these very long reports that people write? So we've come to this, and it's partly due to the Amsterdam working group, where we tend to use synoptic reports, to help us to make diagnoses which are clinically relevant. So there are categories, diagnostic categories. I'm still on. There are diagnostic categories that now, gosh, what's X? Nine categories which encompass evidence of maternal vascular malperfusion, category 2, decidual arteriopathy, 3 is implantation site abnormalities, 4, of course, we're talking about intrauterine infection, which is pretty common, and then 5 and 6 talk about fetal villus maldevelopment and fetal malperfusion, and then 7, we don't see that much in the lab, but that's evidence of uteroplacental separation. Fibrinoid is fairly common. Thrombi, we don't see those that much as well. I think those placentas are not currently submitted. And then evidence of chronic inflammation, we do see it on occasion. So this synoptic sort of report or chart helps us really to make diagnosis, which are clinically relevant. I often get questions whether we have immunohistochemistry available. Yes, we do, but it's not particularly useful in the placenta, except in the case of identifying infectious organisms, e.g. viruses, etc. Right, so I've spoken about this already. And the comment section, like I said, is really useful to try and do what we call clinical pathologic correlation. But it works best when we've received adequate clinical data from the clinician. Okay, so the classification really is those 9 or 10 categories I've already referred to, so we'll skip that. And then I'm just going to show you a few pictures of some of the more common microscopic lesions that we see in the lab. Fetal vascular malperfusion, we do see it once in a while. I think the pathophysiology is really due to some cessation of blood into the placental villus tree, so some vaso-occlusive lesions somewhere in the fetal vascular space leads to this involution of villi, and eventually they may actually become avascular. So of course the list includes prolapse of the cord, hypercoiling, knots, velamentous insertion, which predisposes it to trauma, etc. Okay, so that's one placenta which had a chorionic vessel thrombosis. So you can see the pale areas on the placenta. This is the gross examination. So there's quite a bit of a degree of infarction or and hypervelocity. And then at on B, you can actually see the thrombus completely including that chorionic vessel just underneath the membrane. And you can see the avascular chorionic villi in panel C. So we do see that once in a while. Another one that we see, I think probably one of the more common diagnoses we make on the placentas that we currently receive is some sort of maternal vascular malperfusion. And of course, the pathophysiology is thought to do with implantation being abnormally shallow, etc. You do get vascular damage, which is often called decidual arteriopathy, and so the villi are more developed microscopically. They show accelerated maturation. They show the Tenney-Parker changes, which are just syncytial knots. And you get villus hyperplasia. So we can see two examples of this phenomenon here. Accelerated villus maturation. So if this was higher power, you'd be able to see the Cheney-Parker changes. But you can see how the villi are quite small. So that's the hypoplasia, and there's this increased deposition of the pink fibrin anyway, the increased perivillus fibrin deposition. On the right, you can see the so-called decidual arteriopathy. So the decidual vessels show what's called fibrinoid necrosis. So that pink, increased pink coloration of the vessel wall is fibrinoid necrosis. And this space contains foamy macrophages. And together, that's the so-called decidual arteriopathy. In the lab, like I said, we don't see placental hematomas that much, but we do see this quite a lot when we do maternal death autopsies. Abruption is fairly common. When I was actively doing autopsies, I used to see these cases at least once a month, if not several times a month, from the various districts of the country. So this is just an example of chronic placental, retroplacental hemorrhage, actually resulted in fetal death at 26 weeks. So you can see the organizing hematoma just behind the placenta there. And then B is an acute one, so the placental disc doesn't show many changes, but thankfully the clot was submitted together with the placenta, and it was then characterized. This is a microscopic. You can see the organizing clot behind. Abnormalities of umbilical cord insertion, not commonly seen in placentas we receive in the lab, but in the autopsy suite, we do see on occasion filamentous or membranous cord insertion, and always there's a bit of injury, like we see here. This one was ruptured, and this is the microscopic of that ruptured vessel, and this led to neonatal anemia of some sort. All right, I think this is quite common. We see maternal and fetal inflammatory responses for so-called ascending bacterial infections quite commonly. And we know that the fetal response occurs over the age of 20 weeks. And this is a microscopic, these are actually micro abscesses within the parenchyma. And the microscopic correlates with, I'm sorry, the picture is a bit small, but this is a neutrophilic infiltrate within the membranes with some necrosis. So it's a necrotizing sort of process. Chronic velitis, I think, is fashionable among placental pathologists at the moment, whether we know the majority of cases are actually non-infectious, so-called velitis of unknown etiology, but this is a histopathologic diagnosis. The infectious one, I think commonly we used to see malaria, but not so much nowadays. And there are a variety of theories as to what's actually happening for you to develop the VUE. On microscopic, okay, so first of all, this is a chronic velitis due to an actual infection, so CMV. These are the typical viral inclusions that we see on the microscopic. And you may use immunohistochemistry, where this brown stain actually illustrates viral proteins which have been marked by our stain. The non-infectious one actually involves the infiltration of the intervillar space by macrophages with some lymphocytes. So it becomes very cellular within the intervillar space and don't see much blood. If you do immunohistochemistry like CD68, you can characterize the macrophages very well. All right, I think this is one of the last ones. We've seen a few cases in placentas we've received. Massive fibrin deposition and maternal flow infarction. Really what's happening, there's increased deposition of fibrin within the parenchymal placental disc. And there are a variety of etiologies which have been suggested, which range from autoimmune, latent infection, and to major issues. And I think it's an important diagnosis to make of the associated poor outcomes and the risk of recurrence. I think some authors say 20%. And this is what we see. Essentially, the placental disc is very pale or whitish. It's a fibrinoid which has been deposited within the parenchyma instead of the reddish, brownish reddish, spongy appearance. And you can see the same pink material deposited throughout with associated ischemia of the villi. This is why it's so critical, because it causes very significant ischemic changes. All right, I think, like I said, the last one, the very last one that we see is I think this is a typo, supposed to be chorangioma, most common tumor of the placenta that I've seen, and I think literature talks about as well, the chorangioma. Usually of no clinical significance unless it involves more than 30% of the placental disc. I'll show you a picture just now. But of interest, we've seen quite a number of somatic tumors in the parenchyma of the placenta. We don't have statistics for our local placentas, but elsewhere, melanoma is the commonest, followed by breast carcinoma, and then hematologic malignancies. The chorangioma, pretty big lesion. I think it effect on the fetal outcome. And of course, it's just a vascular lesion, well circumscribed vascular tumors of capillary caliber size. All right, so that's a very brief overview. Just try to highlight what we're doing to try and standardize pathology, make it easier to interact with fetal medicine specialists, and of course also make life of non-specialist pathologists easier in assessing the placenta. Thank you.
Thank you so much, Dr. Zambuko. Very informative presentation. Please keep your questions with you. Dr. Zambuko will be available to answer questions shortly. We're going to move on to the next presenter, which will be one of our students. She's a radiographer student within the University of Zimbabwe, and she wants to present her work, which she did recently as part of fulfillment of a degree program. So, yeah. So her name is Sheila Kanyimo. She's going to present to us on the relation between placenta atal Doppler's FGR fetus. So I'm going to call Sheila to come through. Then after Sheila is done presenting, we are going to open the room for questions or address all the questions that may be in the chat box. I'll just share her screen, then she can come through and start the presentation. Right.
Hello, everyone. My name is Sheila Kanyimo, and I'm honored to be speaking at Fetal Medicine Foundation Zimbabwe platform today. As a final year radiograph student at University of Zimbabwe, I have had the opportunity to work with many expectant mothers and their unborn babies. So this opportunity granted me the permission to carry out my study on the relationship between placenta crate and uterine artery Doppler in FGR babies. Basically, this is the overview of my presentation. Much of the work has been said already. So placenta creating, when we are saying placenta creating, it means we are evaluating the placental maturity based on sonographic appearance of the placenta. Creating helps us to determine if the placenta is functioning properly and if there are any potential risk to the fetus. So cranium classification is the common system used to create placenta maturation. As shown on the diagram, cranium classification categorizes placenta grades into 4 categories, grade 0 to grade 3. So basically, grade 0 placenta appears before 18 weeks. The placenta is smooth chorionic plate and it is homogeneous in echo texture. Grade 1 placenta usually is found between 18 to 29 weeks. It shows randomly distributed calcifications and subtle indentations of the chorionic plate. Grade 2 placenta usually found between 30 to 38. Now, on grade 2 placenta, we found multiple calcifications that are present in the chorionic plate, but they do not extend to the basal plate. Grade 3 placenta shows hyperechoic lines reaching up to the basal plate, large calcifications and indentations that are more pronounced in both the chorionic plate and the basal plate. So, grading of the placenta helps us to see the function, if the placenta is functioning properly. So this cranium grade is used specifically in normal pregnancies. Therefore, if we encounter mismatched grades, particularly the placenta before 36 weeks, this signifies the possibility of placental insufficiency. So, as already mentioned before, maternal vascular malperfusion is the one or is the most common cause of placental insufficiency. So, it is important to assess the uterine arteries to see if they're functioning properly. Abnormal uterine artery Dopplers can be an early indicator of placenta insufficiency, since it is the one that supplies nutrients and oxygen to the fetus through the placenta. Basically, the placenta grade and uterine artery Dopplers are both important measures used in obstetric ultrasound to assess the health and well-being of the fetus. So the main objective of my study was to determine the relationship between placenta grade and uterine artery Doppler in growth-restricted pregnancy. And the sub-objectives was to determine the proportion of FGR pregnancies with abnormal placenta, as well as the proportion of FGR pregnancies with abnormal uterine artery Dopplers. My study was a retrospective study conducted by collecting data on growth-restricted pregnancies from 2 fetal medicine units in Harare. A total of 500 pregnancies diagnosed at 20 to 36 weeks diagnosed with FGR at 20 to 36 weeks gestational age were included in the study. The data was analyzed using this SPSS software, and ethical approval was granted by the Joint Research Ethics Committee. Here are the results of my study. I found that about 72% of FGR pregnancies are predominated by grade 3 placenta, that is the abnormal placenta. Since my research was focusing on 20 to 36 weeks, so appearance of grade 3 placenta signifies the possibility of placental insufficiency. On uterine artery Dopplers, the mean, about 7% of the mean uterine artery Dopplers were normal in my case. And when I used the right or left uterine artery Doppler, I found that about 66% of the uterine Doppler were abnormal. Therefore, I categorize my data into early onset and late onset fetal growth restriction. And on absolute numbers, I found that placenta.
Sorry about this. I think the slides were not moving. We correct this in a second. Sorry about this. Let's we're going to correct this. And Sheila might have to just restart quickly. We have the time for her to just go through the presentation again for the benefit of everyone in the meeting. Share.
For that, so this is the outline of my presentation. As I said before, placenta grading, we are evaluating the placenta maturity based on the sonographic appearance of the placenta. And this helps us to determine if the placenta is functioning properly and if there are any possibility of risk to the fetus. So the most commonly used grading system is the Granum classification that categorizes the placenta grades into 4 grades. That is grade 0, 1, 2, and 3. So basically on grade 0 placenta, our placenta appears smooth on the chorionic plate with homogeneous echo texture. Grade 1 placenta, the placenta appears with randomly distributed calcifications and subtle indentations on the chorionic plate. Grade 2 placenta, we found multiple calcifications that are present on the chorionic plate, but they do not extend to the basal plate. Grade 3 placenta, we found diffuse hyperechoic lines reaching up to the basal plate. There are large calcifications that are both appears on the chorionic and the basal plate. So knowing placenta grades helps us to determine if the placenta is functioning properly and if there are any risk to this. So mismatched grades, particularly the appearance of placenta grade 3 before 36 weeks, gives us the suspicion that there could be placental insufficiency. As alleged before, maternal vascular malperfusion is one of the common cause of placental insufficiency. Therefore, uterine artery Dopplers must be assessed to see the pathophysiological of the placental insufficiency. Normally, in early pregnancy, the uterine artery Doppler shows high blood flow resistance, which gradually decreases as pregnancy progresses. However, in growth-restricted pregnancies, the uterine artery shows persistently high resistance, which is indication of impaired blood flow to the placenta. This will usually lead to the placenta insufficiency. So abnormal uterine artery Dopplers can be an early indicator of the placental insufficiency. Therefore, placenta grading and uterine artery Dopplers are important measures used in obstetric ultrasound to assess the health and well-being of the developing fetus. So the main objectives of my study was to determine the relationship between placenta grades and uterine artery Doppler in growth-restricted pregnancies. The sub-objectives of my study was to determine the proportion of abnormal placenta grades in FGR pregnancies, as well as the proportion of abnormal uterine artery Dopplers in FGR pregnancies. So my study was a retrospective study conducted by collecting data from on growth-restricted pregnancy from 2 fetal medicine units in Zimbabwe, Harare. A total of 522 pregnancies that were diagnosed with FGR at 36 weeks gestation were included in the study. The data was analyzed using SPSS software, and ethical approval of the study was granted from Joint Research Ethics Committee. These are my results of my study. I noted that about 72% of placenta grades were abnormal in FGR pregnancies, and about 57% of mean uterine artery Dopplers were abnormal in FGR cases. When I used either right or left uterine artery Dopplers, I noted that about 66% of the cases had abnormal Dopplers. I categorized my data into early onset and late onset FGR, and on absolute numbers, I found that in early pregnancies, there are a bit small percentage of abnormal placenta grades and abnormal uterine artery Dopplers. However, the p-values were not calculated to see the statistical significance of the difference in these data. Moving on the association, that is the correlation between placenta grades and uterine artery Dopplers, I found that in early onset and late onset placenta grade, the association between placenta grades and between abnormal placenta grades and abnormal uterine artery Dopplers were not statistically significant. However, when I calculated on overall cases, I found that the mean uterine artery Doppler and placenta grade, the association is not statistically significant. However, when I used either right or left uterine artery Dopplers, I found a statistically significant relationship between the abnormal uterine artery Dopplers and abnormal placenta grades. So this tells us that placenta grade and abnormal uterine artery Dopplers are independent predictors for fetal growth restriction. There is an insignificant association between abnormal placenta grade and abnormal mean uterine artery Dopplers. However, as I said before, a statistical association between abnormal placenta grade and either right or left abnormal uterine artery Dopplers was observed. In conclusion, knowing the relationship between placenta grade and uterine artery Dopplers helps us to stratify those pregnancies that are at high risk and those that are at low risk. Knowing the high risk group helps us to monitor the surveillance and the surveillance of the pregnancy, determining the time of delivery and also the mode of delivery. So I recommend that placenta grading and uterine artery Dopplers must complement each other in the assessment of fetal growth restriction rather than to be used interchangeably. Okay, I would like to acknowledge Fetal Medicine Youth Foundation Zimbabwe to give me this opportunity to present the findings of my study. As well, I want to acknowledge Parenyato Group of Hospital and Salim Gabe Hospital Fetal Medicine Unit staff for helping me to carry out my study. Thank you so much.
Thank you so much, Sheila, and well done. Now is the time for questions. If we go through the chat box, I think Prof asked the question, should we promote routine placenta histological palsy and legal challenges? I was discussing with my histopathology colleagues before he left for another meeting. He was of the probably is a correct thing to do because this may help in terms of the cerebral of the medical legal challenges that come with poor neonatal outcomes. But we may hear from the other panelists here what they think, because it's important that we hear from the other panelists what they think of this. Then is umbilical cord hypercoiling a placenta problem or an isolated umbilical cord problem? Again, I discussed this question with our histopathologist colleagues. He was of the opinion again that if it was isolated, in his own view, there is no poor neonatal outcome associated with this. But if, of course, if there are other associations, he would consider it a problem. So yeah, but we are open to other panels. Then any other question we have, either you can raise your hand to speak, or if you're a panelist, you can unmute yourself and speak. If you are not a panelist, please type your questions in the chat box so that they can be responded to, considering the 3 presentations that you have taken place. Yes, Prof, please go ahead and speak. Professor Nicolau has raised his hand. You may go ahead, Prof. Prof, you wanted to say something, please go ahead. So there's a question from Dr. Dragana here. She is asking the histopathologist who has just left on why Lancet, the local laboratory in Harare, why they're not doing histochemistry. Yeah, why they're not doing histochemistry when they have it. They promise to come. Maybe we'll ask him to respond to this and type in the chat box when he comes back. Very good question. Then I think on one of my slides where it should be 4 centimeters on the placenta thickness. Please take note of this when you go through the slides again on placenta thickness. Do you have any other questions? If we do not have another question, we have the pleasure to be on time and to continue with the program. Prof, I believe Prof is in the meeting and is ready, Prof Nicolau. Let me take these few minutes to introduce him so that we can start in advance. Sheila may stop the screen sharing so that Prof can share his screen when it is time to do so. Another question before we move on. Dr. Due is asking, thank you, Sheila. Did you manage to find significant correlation between placenta gradient and the IGR? Hello, services late. Sheila, you can respond, but from what I understand, a study didn't look at this at all. So I doubt she managed to look at it. But it's a valuable question, which finds between placenta gradient and the IGR. Yeah, she didn't look at it specifically. If we don't have further questions, Prof is raising the hand. Prof, please go on. Let me see. Are you in the? You are not in the panelist, so we have to promote you to a panelist. Let's see. Sorry, Prof. I'm sorting it out just now so that we can. Yeah. Prof, I've allowed you to speak and they've promoted you to a panelist so that you can join as a panelist. While Prof is preparing to speak or to comment, let me introduce Prof. Let me
Hello?
introduce Prof.
You hear me now? Dr. Varela?
Yes, we can hear you.
Okay, it was I was talking, but I was talking to myself.
Right.
So I suppose you can introduce me, then I can start talking, then I wanted to raise actually a point about the placenta pathology as a routine assessment for medical legal purposes and CP. I think it is, if we can afford to do this kind of thing, it's a very good idea. The only problem is we get very non-specific answers, like your colleague just now before he left, talking often about fetal vascular malperfusion, which basically means just about every pregnancy will have that histologically. So that's a useless piece of information in terms of defense of a placenta insult that could actually lead to an adverse outcome. But nevertheless, that's for the pathologists to guide us, and I'm not an expert by no means in this subject. So that's what I wanted to say.
Thank you so much, Prof. Very valuable. My colleague from Bulgaria, Dr. Slaviana Galeva, is in the meeting. We were discussing this topic yesterday. Dr. Slaviana, do you want to pass a comment before Prof starts presenting?
Yes, hi everyone. So we usually in Bulgaria send placenta for pathology examinations only in stillbirth cases or abruption, just again for the medical legal issues. But we have the experience that even if we send placenta from normal pregnancy, low risk pregnancy, we get almost the same results. So it's not so useful for us for the counseling and for the next pregnancy.
Thank you so much. So the issue of placenta pathology is quite, we are getting the same experience. We started sending placenta for pathology. The reports are almost the same. When the clinical pictures suggest they should be different. So I hope my pathologist colleagues will come and we have some time to discuss with the pathologist in terms of what could be the best. Are we the ones missing something, or what is it that is happening that you see a totally different clinical picture between your two patients, but the histopathology report is the same? So without wasting much time, it's now 10 o'clock. I'm going to call upon Professor Amos Nicolau. He's a professor of obstetrics and gynecology at the University of Wits in South Africa. And he's the head of the Division of Maternal and Fetal Medicine. He is also the member of the executive committee of the South African Society of Obstetrics and Gynecology and an examiner with the College of Medicine in South Africa. He is going to present on ischemic placenta diseases and thrombophilia. Prof, over to you.
Thank you, Mr. Chair. And can you see my screen?
Yes, we can see your screen.
All right, let me just go to slideshow. Right, you can all see my screen and you can hear me, yeah? Hello?
Yes, Prof,
Okay.
loud and clear.
Thank you very much for the invitation. These are such important topics to discuss, and you know, it's difficult to put everything in one session or one day or even one conference because there's so much to discuss. I'm going to approach this topic from the clinician's perspective because there's so many angles to this topic, from the histopathologists to the radiologists to you know, all sorts of experts that are involved with maternal and fetal care. So I will try and approach this from a clinician point of view and try and make a few practical points. But starting from the very beginning, when we screen in pregnancy, our aim is to reduce the number of neonatal morbidity and mortality and maternal morbidity and mortality. And I have listed there 4 categories or 4 groups of reasons why we have adverse outcomes. And as you see on from the pie chart below, the majority of neonatal morbidity and mortality is actually due to prematurity, and the second biggest group of adverse outcomes is intrapartum related events. So when we talk about prematurity, this can happen for 2 reasons, either because the environment where the baby lives in is not friendly to the baby is not happy in there, and we need to take that baby out to save it, or because the uterus cannot keep the pregnancy in, call it cervical incompetence, or also there are other issues as well, but for the sake of time, call it the main culprit would be the inability of the cervix to keep the baby in, and this baby comes out prematurely. A recent study that was published in the Lancet in 2019 from Chris Hani Baragwanath Hospital looked at the causes of stillbirths among women in our cohort in Chris Hani Baragwanath Hospital. And as you see, a big number of those stillbirths were due to hypertension, nearly 20%. And also pathological placenta conditions, another nearly 20%, which I believe overlaps with the first group of hypertension. So if you combine the two, you get nearly 40% of the cases of causes of stillbirths are due to hypertension and placenta pathology. And there are other issues. There are the maternal medical conditions, infections in the pregnancy, which I must add is very underestimated and underreported in our setups. Infection kind of gets spoken a lot less than what it should be. And interestingly, in that cohort that was studied at Chris Hani Baragwanath Hospital, although there was a fair number of HIV positive patients, none of the stillbirths that were reported in this study were recorded as being caused by these infections. A recent report by the World Health Organization that was published in 2020 highlighted a problem that we always know, we are aware of it, and we struggle to accept that this is entirely true. But nevertheless, in 2020, the World Health Organization reported that about 70% of all maternal deaths were in sub-Saharan Africa. That's us, which is more than double that is compared to the global rate of maternal deaths. And the leading causes, according to the report, were again severe bleeding, high blood pressure, pregnancy-related infections, and complications from unsafe abortion and underlying medical conditions aggravated by HIV, malaria, and so on. The challenge, of course, with placenta ischemia and preeclampsia that eventually lead to fetal growth restriction is multifactorial. If it was one condition that causes placental insufficiency and preeclampsia, that would be easy to manage. But because it's so multifactorial, it is challenging to diagnose and to treat appropriately. So it could be due to fetal problems, such as chromosomal abnormalities or genetic syndromes, could be due to maternal issues, idiopathic chronic disease, abnormal placentation, and conditions such as preeclampsia, HELP syndrome, antiphospholipid syndrome, and so on. It could be placenta problems, mosaicism, or abnormal uterine anatomy. And you've heard with the previous speakers the term of velamentous insertion, which can often lead to IUGR. And of course, external factors, environmental factors, smoking, alcohol, drug usage, and so on. We know from years of looking at these conditions that there are some common culprits that we know are strongly associated with ischemic placenta disease, such as hypertension, abnormal uterine artery flows, and the issue of thrombophilia, not just antiphospholipid syndrome, but thrombophilia in general. And I'll come back to that in a few minutes. And other less probably significant factors such as family history, previous preeclampsia with a previous pregnancy, advanced maternal age, and of course, youth is a good thing on the side of the mother. And funny enough, a bit of smoking seems to be beneficial in terms of preeclampsia, although obviously smoking, as you know, has so many other adverse effects. So we wouldn't really promote smoking to prevent placenta ischemic disease. Looking at our own clinics at Chris Hani Baragwanath Hospital, from our antenatal clinics, we can see again, and I highlighted these in red and blue, 11% of the patients that present to our antenatal clinic are due to hypertension. Diabetes is very high, 7%, poor obstetric history, about 4%, and the issue of twins mustn't be underestimated, because I will show you a slide later, also contributes to the placental disease and preeclampsia IUGR. We have now learned a great deal about preeclampsia, and we're dividing preeclampsia now into early preeclampsia and late preeclampsia. The early preeclampsia is the one we all understand and learn from medical school, that will present with the asymmetrical IUGR. The Dopplers will gradually become abnormal. This baby struggles to grow beyond 500 or 700 grams. And those are easy to diagnose because the blood pressure would go through the roof. The baby is not growing. That's difficult to manage and have a successful outcome. The late onset preeclampsia, which is mainly, I would say, placenta aging, is more difficult to diagnose and often remains undiagnosed, because how often do we hear from history from our patients that they had a previous pregnancy and the baby was 2.4 kilograms, and you say, but was it full term? Yes, it was full term. Did you smoke? No, I didn't smoke. And I believe these cases actually were missed, and these cases could well be late onset preeclampsia and fetal growth restriction. Thankfully, the majority of these cases end up being okay, have a good outcome, and even if we don't miss them, it's not a train smash, although this can be debated, that is not completely unproblematic. Of course, the challenge is, if we don't see the patients early enough to classify them into high risk and low risk, and we see them when the preeclampsia or the pregnancy-induced hypertension and IUGR set in, they enter one common pathway, and sometimes it's very difficult to go back to the beginning and be with certainty make a statement regarding the underlying pathology. Once the poor placentation sets in, and that's obviously in the first trimester, regardless of the cause, the placenta eventually will become insufficient to provide adequate nutrients and oxygen to the baby, and the baby will not thrive, will not grow, will become growth restricted, and the mother will develop the symptoms of preeclampsia, which is in a way, as a simple explanation, an attempt, if you wish, to reject that fetus because it's immunologically is not really friendly to the maternal body, and this can lead to all sorts of problems. The mother goes into severe organ failure, blood pressure goes through the roof, and of course, the placenta can also separate prematurely and cause placenta abruption. So what is the key word here is early assessment is key to manage a patient properly and based on what you have identified as the underlying cause. We have learned a great deal about screening for preeclampsia from the first trimester, and I have put in just two groups of biomarkers. The one is the biochemical markers, which is the PAP-A, the placenta growth factor, and the S-fleet over PLGF ratio, and I will speak about these things in a moment. And the biophysical markers, which is basically essentially the blood pressure and looking at the uterine arteries. And by doing so, early in the pregnancy, we are able to classify low risk and high risk, and those who are high risk, obviously, with appropriate medication, we may succeed in having a good outcome. Even if it's not a full-term 3.5 kilogram baby, will have a good outcome. So if we dissect those two statements, the biomarkers, the biophysical and the biochemical markers. Biophysical markers, looking at the uterine arteries is one of the easiest things nowadays we can do with our ultrasound. We look at the uterine arteries, and if we see good endostolic flow, that's a good thing. It means the vasculature, the blood vessels that provide the oxygen and the nutrients to the placenta bed have opened up, became a low pressure system, and that's what you want. But if you see a high resistance system with a notching and a very low endostolic or very poor endostolic flow, that is a sign that the vasculature did not respond well or adequately to the pregnancy hormones, and this remains a high pressure system. And a high pressure system, like a hose pipe trying to water a big garden, if the garden grows bigger and the trees grow bigger and you need to give more water, if your hose pipe is tiny, it will be inadequate to maintain the growth of these plants in your garden. The same applies to the placenta. The biochemical markers, particularly the placenta growth factor and the PAP-A, are very significant nowadays in our assessment of placenta well-being or placenta health. We know that the PAP-A and the PLGF, the placenta growth factor, are much higher in the Black sub-Saharan African population than the Black patients elsewhere in the world. And we say that because of the Fetal Medicine Foundation studies where the PAP-A and the PLGF were analyzed, the Black patients in their cohorts were not necessarily Black sub-Saharan African. We submitted results recently to the Fetal Medicine Foundation of about more than 10,000 patients in our setup, where they have confirmed that the PAP-A and the PLGF are definitely up to the range of about 50% higher compared to the white South African patients and the patients that were studied in the UK. That has great implications because we are probably providing a poor service to our Black patients because we didn't realize that a higher that they come with a higher with a PABA that may look normal based on our results from the Fetal Male Foundation, but that actually would mean this patient has a low PABA, because by default that patient should have a higher PABA, if you understand what I'm saying. So the PLGF is one of the things that we have looked at, and we know that the more PLGF we have and the less soluble fluid we have, the better it is. And that obviously raises the next point, which is, okay, if we know that low S fluid and high PLGF is good, why don't we look at the ratio of those two and try and make a prediction? That's exactly what happened. Studies were published, and one study was published in the New England Journal of Medicine already some time ago, the so-called prognosis study, where they showed that when you have a low ratio of S fluid over PLGF, that's a good thing, and that's mainly for the second and third trimesters, as a good negative predictive value test to say that a patient with a low ratio is not about to develop preeclampsia. And a patient who has intermediate or high ratio, then obviously that patient is probably destined to develop preeclampsia in the next couple of days or weeks. So the beauty of obviously these comments is that a patient who has a low ratio, even if she presented to, say, Baragwanath Hospital labor ward with high blood pressure, that's a high blood pressure probably caused by something else, and probably that's a transient phenomenon and not a patient that is destined to develop preeclampsia. Again, remember what we said about the ratios. With these studies were done in North America and Western Europe, and did not necessarily include Black Sub-Saharan Africans. Now, with the new values in mind, that the PAP-A and the PLGF in our cohort here are higher, then these numbers need to be revisited. And that's the second study that we are currently performing to see what are the correct values for our patients in our cohorts. The PAB-A, we always did the PAB-A as a marker for Down syndrome. We always suspected the issue of PAB-A and placenta function, but again, we didn't have enough strong data to use the PAB-A as a predictor of good or bad outcome. But now we have enough data to know, and we have looked at our own numbers in our university, and we know that the lower the PAB-A, the higher the risk of a patient to develop high blood pressure, abruptio, and for the baby to end up in a neonatal ICU. So I remember many years ago when I was talking at a meeting about routinely looking at the uterine artery Dopplers and measuring the blood pressure, a lot of people, particularly private gynecologists, had a problem with it, and they said, but that's not for you to tell us whether the patient has a high blood pressure or not. That's our job. For you, your job is to look at the fetus and tell us if the baby is abnormal. That was such a wrong statement. We had an argument then. We still argue with some people today, but it is here, and this is a slide from Kypros Nicolaides from the UK. If we look from the first trimester at the uterine artery pressures, the mean arterial pressure of the mother, and put either the PLGF or the PAB-A or both together in the first trimester, we have such a fantastic detection rate that nobody should be arguing about this. Kypros Nicolaides, for a very long time, looked at the value of aspirin in terms of prevention of preeclampsia. Many years ago, Chrissy Yu, who was one of the fellows in London in 2003, looked at the value of aspirin in the second trimester, combined basically with a 20-week scan. And those who had abnormal uterine artery Dopplers and so on were given aspirin, but the results were completely similar to those who received placebo. The answer was it was too late. Then fast forward many years later, aspirin was same amount of aspirin, but was given in the first trimester to patients who screened positive for preeclampsia, and that worked pretty well. I know I'm taking a lot of time, so I'm going to go a bit faster. Why doesn't aspirin work for everybody then? It would be your next question. If we give it early enough to the patients who screen positive for high blood pressure and preeclampsia, why doesn't it always work? Because there could be unaddressed other pathologies with the patient that we haven't identified. And that brings me to the next slide, that we need to actually get a good history and try and identify personal risk factors that will contribute to an abnormal placentation and high blood pressure and preeclampsia and abruption and IUGR and so on. And these are listed here. There could be just history of cardiac disease or blood pressure or renal disease, could be metabolic issues, obesity. Ask the patient to lose weight. Don't be embarrassed. Patients need to, they have a responsibility as well to be in good shape when they embark on a pregnancy. And the issue of thrombophilia, of course, both inherited and acquired, and that's where the antiphospholipid syndrome comes in, where anticoagulation should be considered. I'm not going to spend any time on the antiphospholipid syndrome diagnosis because I disagree as a principle with this kind of slide where we need to test patients, and if the results are positive for antiphospholipid syndrome, we need to repeat the tests 3 months later, and if that is confirmed, then we classify the patient as antiphospholipid syndrome. That's nonsense, of course, because you cannot afford to wait for 3 months in pregnancy. The baby will either be dead or both mother and baby may be in serious trouble. So we have to make peace with that, that if we have the clinical history, in other words, the 3 consecutive first trimester losses in a normal morphologically fetus, this patient, for example, would be classified as thrombophilia and will probably require anticoagulation. So aspirin and Texan, heparin, low molecular heparin seem to work pretty well. Again, it may not be the complete package. We may need to look at other things that can work as an adjunct to the anticoagulation to optimize results. Again, a lot of these things are still coming in as experimental, and we are looking at these values still as we go. So I said earlier that something about multiple pregnancies. We know that with multiple pregnancies, twins and triplets, the risk of having high blood pressure preeclampsia increases. And again, the comparison between monochorionic and dichorionic twins, also you see the monochorionic twins double the risk than dichorionic twins. Diabetes, again, something that in South Africa is very, very underestimated. We don't ask the right questions. We don't screen our patients routinely, but diabetes is a vascular disease. So, and if you have a condition that affects vessels, the endothelium, like with our earlier slides that I showed you, these patients need to be put routinely on low dose aspirin if they are diagnosed with diabetes, either chronic or gestational. So we need to understand how the fetus reacts to the undernourishment from the placenta. Initially, the fetus will reduce its growth, but will still be kind of within the normal ranges. Eventually, at some point, the growth will cross the line of the 10th percentile, and we will call it intrauterine growth restriction. At the same time, the body of the fetus tries to protect the vital organs, such as the brain and the heart, and neglect the kidneys, and therefore underperfusion of the kidneys will lead to oligohydramnios, and eventually the baby starts being compromised, and that's where the CTGs become abnormal, and this baby then needs to come out, otherwise the baby may end up being damaged. So when we talk about absent end-diastolic flow or reverse end-diastolic flow, we need to understand that these things they're very strong statements. Absent end-diastolic flow or reverse, particularly end-diastolic flow, means more than 70% of placenta is not working. And if you have only 30% of the placenta working, as the baby grows bigger and needs more provision of nutrients and oxygen, it will not get them, and therefore will be growth restricted. I will leave the next to the MCA and the doctor's venosus because I'm sure at this level everybody understands the significance of this. And I will go to the very, very last slide, and I'm going to leave it there because I want to leave you with a clear message. We need, Kypros Nicolaides many years ago spoke about the inversion of the pyramid of care. And together with that inversion of the pyramid of care, we need to understand what it means. We cannot just say, let's invert the pyramid of care. We need to have a clear plan of action in our practice to try and identify those who are at risk. For example, even before pregnancy, address those personal risk factors, lose weight, for example, put them on anticoagulation if they have coagulation issues, sort out their general health status. And then once she's pregnant, we need to look at, obviously, assess the fetus for abnormalities, but also get a good history, measure the blood pressure, look at the uterine arteries, look at the biochemical markers if we have them, if they're available, and start with aspirin or aspirin plus other things, depending on what is the underlying condition. And when we get to the third trimester, is there a place for a routine third trimester scan? No. But those who screen positive and you worry about them, you will monitor them in the third trimester. And those who have early growth restriction, and if you have reverse or absent diastolic flow, you may want to deliver them at 34 weeks or 30 weeks, or if the ductus venosus is abnormal, even earlier, provided your facilities can obviously support these seriously growth restricted babies. And of course, the issue of the late IUGR, which is, as I said, a lot less serious, if you wish, but also a lot more complicated to diagnose. But if you do make the diagnosis of late onset IUGR, you may want to consider delivery at 37 weeks, usually by cesarean section. I'm going to leave it here. Thank you. And I will be happy to answer questions later. Thank you.
Thank you so much, Prof. Very informative presentation. I'll call the next for the next. We can ask Prof some questions. The screen. So the next speaker is Professor Lauren Choke. Is the current head of obstetrics and gynecology, the Charlotte Makeke Johannesburg Academic Hospital Cluster, and is the assistant head of School of Clinical Medicine at the University of Wits. He completed his primary and high school in Minga village in Limpopo and proceeded to study for his undergraduate medical degree at the University of Cape Town. And he also did his postgraduate at the University of Pretoria. And he currently holds a diploma in HIV management, a fellowship from the College of Obstetrics and Gynecology. He's also a graduate in Masters in Clinical Research from the University of Liverpool in the UK, and he holds a PhD in Obstetrics and Gynecology from the University of Free State. He is a maternal fetal medicine subspecialist, and he holds a Bachelor in Theology from Auckland Park Theological Seminary. His research interest is maternal health and health system. Ladies and gentlemen, let's welcome Professor Chauke as he shares with us his work. He's already sharing the slide. Prof, kindly go ahead. Thank you so much.
Thank you, Dr. Varenga, and good morning, colleagues. It's always a pleasure to join you. I'm trying to move my slide. Oh, okay. So that's the outline. I've got a little bit of internet problem, so you might, if you don't hear me, please shout. I'm gonna talk about the placental tumors and the value of ultrasound examination. I'm gonna share one of that I've recently managed. We've heard from the previous speakers that the placenta in our ultrasound medicine fraternity. However, if one looks at the attention paid to placenta, some of the conditions that we found in the placenta, and I've listened to the previous speakers, have got serious implications for the pregnancy, and hence want to pay attention to the placenta. So let me introduce you to Ms. T, just to bring this into context. She was a 30-year-old, grafter 4 para 1, with a history of 2 previous first trimester miscarriages, a cause of which was not established. She had normal booking bloods. However, she was B negative. And the good thing is that Combs, at the time of the examination, which was 20 weeks, was also negative. As I've mentioned, she had had 2 previous miscarriages after a successful NVD attempt. So for all purposes, except for her blood group, she looks like a low-risk patient. She was then referred to us 20 weeks for anatomy assessment. And during the scan, we picked up a 2-centimeter hyperechoic mass. And on applying the Doppler was negative. Then the question really was, what was going on with this patient in terms of what we're dealing with? Was it a bleed? The problem was the location of this mass, which was in the substance of the placenta. But it doesn't mean that it might not happen. Was it chorioangioma? Possible. Some studies suggest that you should be able to see some evidence of Doppler uptake on it. So we were stuck with a patient that we really don't know, a small mass. Baby looks at, as far as ultrasound is concerned, no abnormalities. So we decided, well, we don't know what it is. It could be any of those. And so the patient was canceled, and the attending obstetrician was quite comfortable to do the follow-up. The rest of the pregnancy was uneventful. However, she presented at 7 weeks in labor. And you can see the CTG there. I remember I was attending a meeting in Cape Town, so I got that CTG from obstetrician asking, what should I do? You know, very difficult because you can't remember some of these patients we have seen later on. And the decision was, well, we don't know what is going on, but the CTG is a little bit worrying, so please go ahead and do the Caesar. Caesar was done for fetal distress. A female baby, 2.7 kg with Apgar 3.5 and 6 was delivered, severely acidotic, and was then subsequently taken to NICU. Interestingly, the HB on this fetus, the neonate was fine and did well and was discharged after 2 weeks of staying in ICU. And I think this illustrates the importance, which I've just mentioned, that some of those things looks very innocuous at face value, but the consequences for the pregnancy can be dire, as was the case with Miss T. Unfortunately, with her, the outcome was great. So it's very important when one look at, when you're performing your ultrasound assessment, to spend some time looking at the placenta. And I think Dr. Verenga spoke about this. And I'm just gonna say, for the purpose of placental tumors, you know, he's spoken about the function, spoken about a basic assessment. What I just want to remind everybody is that be systematic. You can imagine if you see that 2 centimeter tumor and you haven't, paid some attention to it, you're going to miss it completely. And when something wrong happens in pregnancy, you have no clue as to what is going on. And for us in fetal medicine, often when you get somebody referred to you and you give an advice, you do a scan and make assessment and, give some advice in the management, most of the obstetrician will never bother to really look at anything later on, because the belief is that this baby was seen by the fetal medicine specialist. So therefore, if they say everything is fine, therefore there's nothing that is wrong with this pregnancy. So they will continue without really paying attention to what is going on. So look at the location it was discussed. And of course, if you've got a placenta previa, you need to make sure that you exclude inversion. But what I want you to look at really is look at the size of the placenta. And again, Dr. Verenga spoke about do a visual estimation of the size. People who scan a lot will be able to say this placenta doesn't look normal in terms of size. And Dr. Verenga also again was kind enough to say that if you can see the placenta, the whole of the placenta on the screen, then you need to ask, is it a small placenta or is there something going on there? And the opposite is true. Look at the placenta, if it looks big, then you really need to start wondering what is going on. And again, you can measure the thickness. Most of the data suggest 2 to 4 centimeter next to the central point of the cord insertion. Most importantly, look at the morphology. How does the placenta look like? Again, I always say this like driving. If you drive very often, it becomes automatic. So if you have seen enough placenta, it's pattern cognition. You will see when something doesn't look okay. Look at for additional lobes. And of course, might find some tumors. He spoke about the cord insertion, which I think is spotted. And of course, Doppler is important, not only for fetal growth, but even for assessment of these masses when you see them. So if you really look at the most common tumors, so these tumors probably affect about 1% of pregnancy. You might say that that's very little, but I can tell you for this year, that was my second chorioangioma that I've seen. Maybe you can say I was lucky to see that. And I've every few years I come across some form of tumors in practice. So when you look at the classification, you've got primary. Your primary is trophoblastic and non-trophoblastic. I don't think I need to speak about the trophoblastic. We all know about the gestational trophoblastic disease, your partial and complete moles. And of course, don't forget your intraplacental choriocarcinoma, because this can have serious consequences for both the mother and the fetus. The most common non-trophoblastics are chorioangioma, the teratomas, and the placental mesenchymal defect, or PMD. And of course, the lymphomas, the maternal secondary is usually advanced maternal disease. I'm going to talk about it a little bit later. But most commonly, you need to worry about your lymphomas as well as your primary lung and breast cancers, which the pathologist has touched on. And it was quite nice to see the figures that he mentioned. For the fetal, the tumors that usually goes to the placenta is most commonly, most often than not, is your neuroblastoma. And that will probably be followed by rhabdomyosarcoma in some cases. But usually, if you come across anything, so neuroblastoma. The problem with the fetal or placental carcinomas and tumors is that these are extremely rare. And really, if you look at the literature, all that you come across is case report isolated from different places. So it's quite difficult to get a comprehensive review of the extent of this condition and how they affect the pregnancies. I'm not going to talk about this because I think nobody really misses this, especially your complete moles. We're all very familiar with this. Patient comes in with symptoms, either they're gonna have high blood pressure, early onset preeclampsia, signs of hypothyroidism, and we do apply, sometimes we get hyperthyroid, and the beta ECG gives us a clue, and of course the ultrasound gives us, the modern ultrasound is not like the old one where people talk about snowstorm appearance. I think here you can see the cyst, and you'll probably see that this placenta doesn't look okay. You sometimes get a mimica, which usually will be hydropic placenta after a miscarriage. But usually in those cases, the beta ECG will be low, so it'll be easy to distinguish between the two. Your partial mold, usually you will see the same thing with a fetus. And of course, we all know that these carry bad prognosis. And therefore, when you see that, you need to be active in terms of management. And usually these fetuses will have IUGR. When we look at the trophoblastic intraplacental choriocarcinoma, and I'm going to just talk about this briefly because this is quite important. This is a rare variant of choriocarcinoma spectrum. Majority of the cases are very small and asymptomatic and are easily missed. And usually those ones that are very small, less than a centimeter, they usually don't do anything. They get picked up at placenta examination for one reason or the other. However, there are some that might present with metastatic disease, and this can go to the fetus or even maternal. In fact, the literature and the case report that are there suggest that if for some reason you suspect during your ultrasound examination in intrapartum, natally, that this patient has got a choriocarcinoma, you need to follow this patient, even if nothing has happened during the pregnancy, the way you will follow somebody with a gestational trophoblastic disease. The challenge with this is this concept of elevated beta ECG, and this always has been an issue. How high should the beta ECG be for one to suspect that this is choriocarcinoma? Should be in the millions, should be in the 100,000, and again, in the lack of systematic reviews and robust data, it's very difficult to advise one when should they be worried. And a clinical assessment is very important. Context is key. If you get a beta ECG that is very high in ultrasonography, you suspect that with a very high uptake of your Dopplers, you really need to put some attention on monitoring and even post-delivery follow-up. What is challenging with these tumors is that it presents a spectrum of disease, might look exactly like the rest of the placenta. So in other words, as echoic. Sometimes you see echoic masses and you don't even know what you're dealing with. And sometimes it may present with cystic changes. And again, it really about you must have a high level of suspicion. And when in doubt, rather err on the side of follow-up and making sure that you don't miss the persistence of the disease, because it can have serious consequences for the mother. The complications of abnormal placenta, so one will expect things like abruptio, your fetal anemia because of the shunting, and sometimes because of the bleed. And of course, this patient tends to present with preterm delivery. However, what is good about this is 60% of the cases will result in live birth with no serious consequences for the fetus. I've already touched on the diagnosis and management as I was talking through the slide. So then you have the one that I've just given you an example, the case report of the non-trophoblastic group, and the most common being the chorioangioma. It's really a benign proliferation of the vascular channel, which is supported by the chorionic stroma. There seems to be some reports that this is common in pregnant women who live in areas of high altitude, and there's been a question whether this is due to hypoxia. Unfortunately, we really cannot say because we don't have enough data to make that conclusion. What is quite notable in this is that if the tumor is very small, so in other ways is if it's less than 5 centimeters, most of these are clinically significant. And in the case that I've given you, it was less than 2 centimeter or plus minus 2 centimeter at the time that we saw this. And unfortunately, we haven't seen this patient later, but it's very clear that at the time of delivery, that tumor has grown, but we don't have the values to say how big was it, because even the specimen that I showed you was basically a tumor that was taken piecemeal, so we're really not able to measure. And I'm not sure whether they struggled with extracting the placenta or they decided to open to see what was going on, and hence they provided us with that picture. The complication for this tumor, again, is fetal anemia, thrombocytopenia because of platelet trapping. They can present with abruptio, preterm labor, and of course, on ultrasound, you can see an echogenic mass. And you can see in that one, hypoechoic in that picture. And if you are lucky enough, some studies actually suggest case report that you might actually not have high vascular intake early on in the early first and second trimester, late first and second trimester. And I suspect that is the reason why we can't demonstrate color Doppler at 20 weeks. The teratomas, again, are the extremely rare, but probably the most second commonest non-trophoblastic tumors. And the teratomas is exactly how we know them. Sometimes very difficult to distinguish whether they're coming from the fetus or they've got their origin from the placenta. However, as you know about the teratomas in gynecology, they're all the same. You've got your benign, mature, or benign cystic teratoma, and malignant immature teratoma, which tend to carry a bad prognosis. The ultrasound features, you can have a mixed picture of mixed solid and cystic masses, and that picture sometimes can resemble a chorioangioma, and it might be very difficult sometimes to know what we're dealing with. 10% of those are completely cystic, and some can be lobulated. What is quite helpful with this is when you found calcification, which is found in about 40%. And if you see that, that's sort of like distinguish teratomas from the others. And usually these tumors have got a favorable prognosis, and usually follow-up is adequate. The third non-trophoblastic placental tumor is your placental mesenchymal defect, or PMD. This is probably extremely rare. It's a vascular tumor. Usually, these mothers will present with huge placenta, which is often multicystic. If you really look closer, you'll find that they've got high vascular uptake, and on pathology specimen, they've got thick tortuous vessels. It's very important when you suspect this to look at the fetal liver, because they tend to present with liver cyst and even vascular malformation on the fetus itself. And so you need to do a proper evaluation of the fetal organ, including the brain. Also been associated with Beckwith-Whitman syndrome. The challenge with that, it's got variable outcome. And again, what I've said initially is that the challenge with this is all that we have is case report. And personally, I haven't come across one, so I don't really have experience. And that would be interesting if any of you, even Prof. Nick, have had any experience in with this condition. The complication, of course, is IUGR, and like the rest of the placental tumors, preterm labor is always a problem. Then it leaves me with one slide, I think that my second last, to just mention in passing that let's not forget about metastatic cancer. And I'm saying this because just yesterday, I saw a patient who was referred to us with Beckett lymphoma at about 20 weeks. And we had a discussion with my colleagues, about the issues about management. Fortunately, she has already started on treatment. And of course, one need to be very careful and put some effort in terms of monitoring these pregnancies. However, if one look at the literature, cancers in pregnancy, it's probably account to 1 in 1,000. So it's not really that bad. So meaning that in an institution like, for example, Bara, where they do about 20,000 deliveries, you're probably going to get about 20 patients per annum. With us, probably looking at about 8 to 9 patients presenting with cancers. So it's very important to pay attention to this. What is very clear now in the literature, and I've just mentioned the European societies, that the treatment should be similar to non-pregnant women. In the past few years where I work, we've lost a lot of patients, especially with breast cancers, because our medical oncologists were not comfortable in treating patients. And from time to time, we have to have a meeting with them to discuss these issues, that we cannot compromise a mother because of the pregnancy. Of course, we know that if we give chemo during the first 12 weeks, and maybe there might be a room to defer if there's still an opportunity, because of the risk of 10 to 20% risk of major congenital anomalies. But that should really be balanced against the risk to the mother. What we need to consider is that there are cancers which will metastasize to the placenta and the fetus. And in particular, you're looking at melanoma and primary pulmonary cancers. And to some extent, your gastric lymphomas, your gastric cancers, your lymphomas in that order. And this was a review by Kazak et al., which was published in 2022. So I think the key message that we really need to consider is that these tumors are extremely rare. And majority of people will not see them in their lifetime, unless if they are working in a referral unit. However, it's very important that even when these tumors are rare, be systematic in terms of the way you look at the placenta. Pay attention the way you pay attention to looking at fetal morphology. And should you have a suspicion that something is happening in the placenta, you're not sure, seek an opinion from somebody who might be an expert in the field, or probably a colleague, and so that we don't miss those tumors that might have severe consequences to the mother. Thank you very much for the opportunity. Dr. Berenga.
Thank you so much, Prof. My computer was getting stuck on unmuting. Thank you so much for the presentation, very informative. I think we'd like to open the room for questions, both for Prof. Chauke and Prof. Nicolau. There are already questions in the chat box. Let me just read some. Yeah. Did I see another question? I don't know what happened to the other question, but the other question was in reference to Prof. Nicolaus' presentation. One of the participants asked if aspirin's effectiveness reduced when commenced after 20 weeks. I think that was the question. They said it's going to be reduced by 50%, something like that. That was the question. I don't know, I think it has disappeared from the chat box, but it was a question posed by one of the guests in the meeting. I don't know, Prof, if you wanted to respond to that.
Yes, I'm here. I can hear you. So it's a very difficult question, and I must admit there is no easy answer. we're very tempted when we see patients even for the first time in the second trimester to consider giving them aspirin, knowing that that aspirin in the second trimester probably will have very little or no effect. Now, the question of do you increase the risk of preeclampsia if you give aspirin in the second trimester for the first time? Again, the studies have shown that there is an increase of abruptio by 2.5%. So I don't have an answer, to be honest with you. Would I give aspirin in the second trimester? Probably not. But I would like to have the luxury of seeing patients in the first trimester and put everybody who scores high for high blood pressure and preeclampsia on aspirin. And again, what is the dosage? In some countries, they don't have Equitrin, they have aspirin. Some countries, they break the aspirin tablet into two, or Disprin. Again, this cannot be an equal amount of half a tablet every time, because you cannot really divide the tablet into every single time at 50-50. So one has to obviously make a plan in their own setup and see what works best for them. And I'm sure in Zimbabwe, like in South Africa, we probably have access to the same kind of medication. If you 150 milligrams of aspirin or 2 Equitrin, which is 162 milligrams, seems to be reducing the risk by quite a lot. Now, whether it's 50% or whether it's 80% or whether somewhere in between, it's debatable, and it has to do obviously with the cohort you're looking at, and also what I said to you earlier with the PAP A and the PLGF in our population that may actually have got it wrong all along, and we were under treating our patients in sub-Saharan Africa because we were going by the values that were published mainly in the white population in the UK and other Western European countries. And remember always to address underlying pathologies as well before you embark on aspirin. Aspirin is not a miracle drug that will solve every problem. You've got to identify underlying pathologies, treat them, and then embark on a pregnancy with aspirin and Clexane if required. Thank you.
Thank you so much, Prof. I think to everyone in the meeting, I think it is very clear that uterine arterial Doppler assessment is imperative, more so in our region where we know that we have limited access to biochemical markers, and even some of our patients may not be done blood pressure adequately. So assessment of the uterine arterial Dopplers is now imperative to everyone who does especially first, even second trimester scans. So there may be some who are still scanning, who are not familiar or who are not competent enough to do the uterine arterial Doppler and also second trimester uterine arterial Dopplers. Please, our fetal medicine units are open to train people how to do it properly so that the women can benefit from these screening algorithms. Because without having people who scan and who can do uterine arterial Dopplers, all these screening algorithms are not going to work for us. So yeah, and the other question which I wanted to, or the other comment which I wanted to pass on the presentations is to do with the placenta assessment. Quite a number of ultrasound scan performers do not check condensation. It is very important to check condensation on the placenta and to have that subjective assessment of the size of the placenta, because sometimes it's greatly overlooked and it's not commented on. Again, it's not a difficult skill to check condensation. You can be trained and be competent in it. But you may need a machine with Doppler, or sometimes without Doppler it may be difficult. Most of our posterior placentas and the fluid is not as good as it should be, but it can also be checked without Doppler condensation on the placenta. So yeah, I don't know if we have any other questions or comments. For our two presenters, Prof. Chauke and Prof. Nicolau. So maybe to just pose one more question on my part to Prof. Chauke. Prof, what could be the detection rate for tumors, placenta tumors, ultrasound scan, placenta tumors? I know they may vary with tumors, but I mean, is there a high false positive rate at all, or once we suspect and we send to the lab, we are more likely to be correct?
So I think the challenge, Dr. Berenga, is what I've just said. If you get a chance, you must look at the literature. It's quite shocking to actually see that there's not much written on placental tumors. You get some few case reports there and there, and everybody has got their different understanding of how we should approach the diagnosis. So I think the simple answer is I really don't know what is the incidence. I don't know if Prof. Nicola has got any idea. I personally don't have it.
I agree with you, Lawrence. And the studies that were done, and one of the biggest names in placenta pathology and assessment is Neil Sabaya from the UK, who many years ago went through his fellowship training in London with Prof. Nicolaides as well. They have shown that the ultrasound it's actually notoriously inadequate to assess probably placenta pathology. We're getting better in assessing placenta function, but placenta pathology and tumors in particular are so difficult to identify. And when you see them, what is the diagnosis? You can say, I see a space occupying lesion in the placenta bed. What does it mean? So I think we still have a long way to go there.
Thank you so much, Profs. Yeah, so the fetal well-being context matters, that the fetus well-being always has to, is the main denominator for us to say, is the placenta well or not? So yeah, very important. Any other questions we want to ask the two profs? Otherwise, I want to thank them for sparing this time to share a very important knowledge with us and to improve our knowledge depth. So if there are no further questions, thank you so much, Prof. Nicolau, Prof. Chauke. Thank you for taking time to do this. This session is coming to an end. That was the first session. There will be a second session, which will start after the tea break. People just go for the tea break. And it will start, it should be around 20 past, half past. We'll start the second session, which will be chaired by my colleague, Dr. Ndagurwa. Otherwise, thank you so much for doing this. And any questions you may have, you are free to think through and post in the chat box. The webinar platform will remain open during the tea break, so you can share your questions there. Otherwise, see you at 11:30 when we continue again. Thank you. Bye-bye.
May I say something? I would like to thank you for the invitation. And if anybody wants to have access to my lecture, I'm more than happy to share. I can share it with you, and then people can access it or put it on your website and so on. Yeah, thank you.
Excellent. Thank you so much, Prof. Your lecture has been recorded, so it will be on our website. Thank you so much.
Okay, so welcome to the second session for today, where we are going to be looking at abnormal placentation. In this segment, we have 3 presenters, and our first presenter is going to be Dr. Anas Alojai. Is Dr. Anas in the meeting already? Hello, Dr. Anas. If Dr. Anas is not ready, we will call upon Dr. Slavi. Are you ready to take over, Dr. Slaviana?
Yes, it's completely fine.
That's okay. So Dr. Slaviana is a specialist obstetrician and gynecologist. She is also a certified fetal medicine specialist who specialized in fetal maternal medicine under the supervision of Professor Kypros Nicolaides from 2016 to 2018 at King's College Hospital in London. She also did medical genetics and immunology at Harvard University in America from 2020 to 2022. She is a research associate in screening for prevention of chromosomal diseases, preeclampsia, preterm birth, fetal growth restriction, and stillbirths as well. She is an author and co-author of articles related to non-invasive prenatal diagnostics using cell-free DNA. At the moment, she works at Sofia Hospital in Bulgaria, where she's working as a consultant in fetal medicine. Dr. Slaviana is actually in Zimbabwe at the moment, where she's here for an exchange, skills exchange program, and she's been giving lectures at Harare Hospital and Salimu Gabe hospitals. Dr. Slaviana, please feel at home in Zimbabwe and please take over.
I already feel at home thanks to you and your warm welcome. So I'm more than happy to be part of your webinar. And let me continue with the presentation. So I will speak about placenta accreta spectrum. The story of placenta accreta starts with the story of Raisa Nitaboh. She was one of the 7,000 girls that in the end of the 19th century went to study medicine in Switzerland. There, under the guidance of Theodor Langhans, he is the father of placentology. All the things that we know about the placenta came directly from him. So there she did her PhD, and she described a layer between the placenta and the myometrium, which is called nowadays the Nitaboh layer. This exact Nitaboh membrane is missing in the cases of placenta percreta, which allows the placenta to grow further into the uterus and the nearby organs. The risk factors, there are lots of hypotheses why this happens, but the risk factors, of course, are previous surgery, age, parity, if we have endometrial scars, and fibroids. There are lots of comparisons between the placenta accreta spectrum and cancer because the same growth factors that are seen in cancer are highly expressed in the placenta accreta spectrum. The first 18 cases were described in 1937. In 1960 was the introduction of the histological classification, and in 1982, the first ultrasound diagnosis was described. What we see nowadays is that the increase in the rate of C-sections worldwide leads to an increase in the incidence of all these past cases, which nowadays are more than 1 in 800. All the cases with placenta accreta spectrum are related with 60% severe complications, and 7 to 10% of the women that they have placenta percreta, they die. The story of Gina Walker is remarkable. This was a mother who required 540 units of donated blood products when she delivered her baby at the University Hospital in the States in 2002. The blood came from USA, UK, France, and Italy. She needed 8 embolizations and 10 pelvic packing, and she survived. Placenta previa and previous cesarean sections. On the table here, you can see the number of previous C-sections and the risk of placenta accreta spectrum. So if we have more than 3 C-sections, the chance for placenta percreta is more than 50%. Of course, this leads to more than 4 times higher rate of hysterectomy. When should we refer the patient to past specialist? So if we have a history of previous C-section, if we have placenta previa, if we have previous intrauterine surgery, if we have bleeding in the first or the second trimester, previous history of placenta accreta spectrum, and if we see ultrasound signs. Now I will show you some of these ultrasound signs, which in experienced hands, they have high sensitivity and specificity. The first one is the so-called loss of the clear zone. On the images on the left are all the normal ones, and all on the right are the abnormal ones. Here, on the image on the left, you can see this hypoechoic plane, which is missing on the right. This has almost 97% specificity for placenta accreta. The next one are the placental lakes, which Dr. Verenga very clearly explained, but I'm not talking about the normal placental lakes that we can observe very often. These are big abnormal placental lakes, and especially if we have placenta previa and they are closer to the myometrium, we should be highly suspicious of placental pathology. This is again loss of clear zone, which you can see here, and this is intraoperative image. The other ultrasound sign is the hypervascularity. Again, this is the normal one, and this is the abnormal. Many societies say that the MRI is the gold standard for diagnosis of placenta accreta spectrum. However, the MRI machine is not the one that is making the diagnosis, it's our radiologists. And radiologists, as well as us, they don't see so often placental pathology. It's not so common to see it, so they can make mistake as well. In this case, by Dr. Chantren, he's showing a false negative case, which the radiologist said that there is no sign of placenta percreta. However, during the surgery, they observed that half of the placenta was inside the intestine, next to the uterus. And of course, false positives. Sometimes the MRI can tell us that there is placenta percreta, but the operator can very easily remove the placenta. So we need people who are experienced in this diagnosis. We need MRI, especially in the cases of the posterior placenta, where it is difficult to see with ultrasound transabdominally, even transvaginally. But to get this experience, our doctors should have referrals from many centers and should upgrade their knowledge every year. What should be the management when we have already done the diagnosis? Usually the delivery is between 34 and 36 weeks, and this is because the higher rate of uterine rupture after this gestational age. And there are two types of approaches. It's either radical, where we do hysterectomy, or the so-called staged hysterectomy, where we wait for the more experienced operator to come and to finish the surgery, or the so-called uterus preserving surgery, when we do C-section and then conservative treatment. We leave the placenta in situ, the triple P procedure, or the partial resection. For the conservative treatment, the majority of the studies, they come from France. So they do the C-section, they leave the placenta. One of the first studies was done again in France. They had 167 patients. In 59% of the cases, they left partially the placenta in situ. In 41, they had left complete placenta in situ. In 22% of the cases, they had subsequent hysterectomy. And in 28% of the cases, the mothers developed sepsis. The complications were either sudden bleeding, sepsis, peritonitis, necrosis of the uterus, developing of fistulas, kidney failure, thrombosis, pulmonary embolism, and even death. Some of the adjuvant techniques that we use to preserve the uterus are either embolization of the uterine artery or ligation, which can lead to uterine necrosis, or the use of methotrexate. And methotrexate, again, it has its side effects. There are reports of death due to toxicity, even one septic shock when methotrexate was administered into the umbilical cord. The idea to maintain the uterus is to preserve the fertility. However, the recurrence risk is high. It's up to 29%. Now I will show you some cases from our friend Samira from Innsbruck. She wanted as well to come this year to Zimbabwe for the teachings. She will do it next year. So these are her cases in Innsbruck University in Austria. What they did was to leave the placenta in situ, and I will show you some of the complications that they experienced. This is a case from 2010 of placenta in Creta and a stillbirth. They used methotrexate, so the C-section was in August. In October, they tried to remove the placenta because of sepsis. They used Bakri balloon to stop the bleeding, uterine sutures, the hemoglobin dropped to 4, and it led to hysterectomy. The other patient is from April 2018. In May, due to bleeding, there was an attempt to remove the placenta. There was intraoperative cardiac arrest, multiple resuscitation, pulmonary embolism, and thrombosis of vena porta. Why to ligate the uterine artery is not sufficient to stop the bleeding? The answer is given by Professor Jose Palacios Jaracameda, who found that the 71% of the blood supply in the lower uterine segment comes from arteria pudendal, the internal pudendal artery. It's not from the uterine artery. And in the case of placenta previa, when we have placenta previa, the newly formed vessels they don't have tunica media, which is very important if you want to try to suture these vessels. It doesn't work. The bleeding cannot be stopped. And you can imagine if you have this type of bleeding, in 10 minutes, the patient can lose 5 liters of blood. The attempt to do hysterectomy in cases of placenta percreta, many surgeons around the world, they call this to play with the devil. That's why Professor Jose Palacios Jaracameda from Argentina, he has a different approach. He proposed a technique called partial resection. In his first study, he had 68 patients, where I will try to show you what was the approach. So he divided the patients in 2 groups. The first one was when the placenta was attached to the upper part of the bladder, and the second group to the lower part of the bladder. And you can see from the data that the placenta that was attached to the lower part, there was, in 91% of the cases, he had to clamp the aorta to stop the bleeding of the patient, to preserve the uterus. This is the technique. He used also a fibrin glue after he removes the part of the placenta which is attached. And he followed 42 patients 3 years after the cesarean section. 10 of them had recurrent pregnancy, and 36 within 36 weeks of gestation with no recurrent invasion. You can see some of the images from the intraoperative images. You see the placenta, the bleeding. It's very important to have a blood bank if you are going to try to do this type of surgery, because the blood loss can be enormous. So till 2018, we had patients, 6 patients with placenta increta. Thanks God, we didn't have patients with placenta percreta. After 2018, I refer all the patients to a multidisciplinary hospital with a blood bank, because it is dangerous. In my hospital, we are only maternity hospital with no blood bank. We have to go with a taxi to get the blood. So it's not, even if you have the best surgeon in the world, if you don't have the blood immediately, the patient is going to die. So we did only hysterectomies in these cases. In 5 of the cases, we had the diagnosis from before. You can see some of the placentas and the attachment to the uterus. And one of the case, we didn't have, it was unrecognized. The patient was not followed. She was 39-year-old. She had 4 abortions, previous abortions. She came at 30. We didn't know even the gestational age exactly, just based on the measurements of the baby. And she collapsed in the corridor of the hospital. We did an emergency C-section, and there was a uterine rupture at the place of the placental invasion. It was at the fundus of the uterus. We did a peripartal hysterectomy, and the blood loss was 2.5 liters. The patient and the baby survived. The baby is with cerebral palsy. These are complications not from our hospitals. I took these images from UK. So this was a patient that the surgery was done by inexperienced doctors when they didn't recognize that it was placenta percreta. And you see again, because of the blood loss, she even had necrosis of the leg. This is another mother of 8 that she lost both her legs because they had to clamp the aorta. And this is the last slide. When we have the diagnosis, we have to prepare a multidisciplinary team. So this is the image that I took from Dr. Amaran Binde from St. George Hospital. You see how many doctors, how many midwives, they need to have radiologists, hematologists, anesthesiologists. Many people are involved to save the mother and the baby. We need to have a neonatology team that is prepared to take a late preterm baby. So we need to have a big team. In the end, what I want to tell you is that the preliminary diagnosis of pathologically attached placenta enables the preparation of a team, which does not always mean a favorable outcome for the patient. The prognosis depends on the depth and the location of the placenta, and we have to be prepared with the complication of spontaneous uterine rupture and hemoperitoneum. Hysterectomy, conservative treatment should be done only in multidisciplinary hospitals. And thank you very much for your attention. I see also that Anas is here.
Yeah, hello everyone. Thank you for the nice presentation.
Okay. Thank you, Dr. Slaviana, for the insightful presentation. I think we can all prepare our questions either in the chat box or we write something down, then we can ask Dr. Slaviana at the end of the session. Next, we are going to have Dr. Anas Alojai, who is a fetal medicine specialist working in the United Kingdom. Dr. Anas is originally from Syria, and he graduated from Aleppo University Hospital in 2002 for his first degree. And he went on to specialize in obstetrics and gynecology and graduated from Damascus University Hospital in Syria. That was in 2008. He then obtained a diploma in fetal medicine from the Fetal Medicine Foundation, United Kingdom in 2020. Currently, he's working as a senior clinical officer at Balsidon University Hospital in the UK. Thank you, Dr. Anas, for joining us. You can take over.
Thank you for the nice, presentation. So I will start from the last what Dr. Slaviana did. Just give me a second, I can share my Can you see my presentation?
Yes.
All right. Okay. So I will start with management of placenta creta spectrum disorder, the excision and anterior placenta creta. So as Dr. Slaviana talked about it, I will talk about this technique actually. So we have at Queen's Hospital at Romford in UK, Placenta Creta Center. So this center started from 2005, and MDT, multidisciplinary team management, started at 2015. So actually we have in this center a good experience about dealing with placenta creta. All the area around Romford in the UK, which is east of London, so send patient with placenta creta to this center. So I will start with actually present a case, which I was in this case, and I found it's very important to spread this knowledge for people who don't have this opportunity to be in the placenta creta center and learn from that. So the case is 34 years old patient. She had type 2 diabetes, and her blood group is A positive. So ethnicity is Asian, Bangladesh. Her family history, she had diabetes in her family. So she had actually in her obstetric history 3 cesarean section, one in 2008, one 2011, and one in 2017. So C-section, the patient was seen in antenatal clinic on 2nd of September and booked for elective cesarean section at 38. Actually, because of she was on aspirin, 150 milligram, and low molecular weight heparin. So her hemoglobin was normal. So actually, we discussed in the MDT, we were not sure about this. She has actually the placenta creta, so at 38 weeks, and we booked her for elective section at 38 weeks. When we explained to the patient, because the patient doesn't want hysterectomy, so we explained everything, actually, the possibility of hysterectomy, possibility of blood transfusion, and the possibility of resection of the anterior wall of the placenta, of the uterine artery, of the uterus. So in the scans, so first trimester and second trimester and third trimester were all fine. So at 30 weeks, the appearance of placenta remains suspicious of morbid adherence. There is a loss of hypoechoic space between the placenta and thin lower segment. This was the only thing in the scans. So actually, fetal growth was normal, Doppler was normal, placenta was low-lying, and we didn't have this evidence of hypervascularity. And was the fetal medicine lead who, did the scan, I was not sure about the actually placenta creta. The only thing we saw that this is the loss of hypoechoic area in some views. So if you see here, I just took this, the only or 2 picture I have, is just the loss of hypoechoic area. We didn't have hypervascularity. We did the Doppler, there was no hypervascularity. It's just we saw that the placenta actually remains suspicious with a morbid adherence and there is a loss of the hypoechoic area, and we will there is hypoechoic space between the placenta and thin lower segment. So the views was actually restricted because of difficulty of the scan. This patient, 3 cesarean section, previous cesarean section, and and was difficult to scan here. So Dr. Slaviana talked about sonographic sign of placenta creta. I will not repeat them, but it's just a reminder: anechoic layer under the placenta, placenta lacune, trophoblastic flow, white line of bladder, uterine interface. This is the kind of, the features we look in. We look actually in the ultrasound to be sure that if there is any, suspicious of placenta creta. So we didn't decide actually to do the MRI because we were not sure. So then the delivery was on 13th of September. So we did bedside scan in theater, placenta brevia with feature. So with lows, as we said, lows of echo lucent area between the uterus and the placenta, clear space. Thinning of hyperechoic interface between the uterine serosa and the bladder wall. And we decide to do the resection of the uterus with the placenta in situ. So this is actually just explaining to the patient what we will do. So we will do just not the the normal lower segment incision. We will do like midline incision on the uterus, and we try to resect the placenta with the uterine wall. So delivery was on 13th of September, was a female, good weight, good APGAR score. So this video, actually, it will take 20 minutes. I will try not to do it 20 minutes. I will just, make it shorter. But this is a work, it took from me 8 months to achieve this video, actually. So, and working with the medical photographer to achieve this, video, to show the people who don't have this placenta creta center. If you are in emergency, let's say you are in Harare, you don't have MDT meeting, and you just maybe have the basic things. And as Dr. Slaviana said, the most basic is the blood bank, because we need blood for this patient. We need to be prepared. But let's say you don't have this equipment or the team what we have here in the placenta center at Romford, even though in the UK there is not every hospital has this placenta center, placenta creta center. I wanted just to show, if you are in emergency as obstetrician and we have to do something, what we can do. So until we, for example, someone arrive, has more experience, or we can transfer the patient to another place, or more people can help us in this situation. So I will start with this video and I will explain everything in details, and I hope you will enjoy it. I will start, and please let me know if you are seeing something. Can you see?
Yes.
Perfect. So if you see here, so we start this the cesarean section. We were not sure, actually. So we were not sure about the placenta creta. Then we extension the incision. So, and now we extension the incision. And you see how is it the appearance of the placenta in the uterine wall. So it's not, let's say, the normal appearance. If I go back here, you see here, before we do here, you see the appearance. When we decided to extension the Finchtail, so we extend, but here the appearance is not normal, what we see usually, though it looks like a placenta come through the uterine wall. So we do now the longitudinal incision, midline incision of the uterus, away from the placenta, where we think is the placenta is close to the bladder. So externalization of the uterus, we decide to take the uterus out of the abdomen. So then we start now excision, or opening the uterus with the midline incision. So after that, we deliver the baby, bridge presentation. So, as Dr. Slaviana talked about one of the, methods, we use this method, actually, the excision. So, and lay the placenta in situ. So the thing is, if you look at it, so we put this here, the clump is close to the placenta base, and we let the placenta in situ, okay, and now we try to close the uterus. You see here, how is the placenta here? Placenta creta, if you can see me here. Yeah. So now we put the Jaco catheter applied temporarily below the lower segment. This is like, the Foley catheter. We put around the uterus. So with the broad ligament and close to the bladder. You see it? You see this Jaco catheter? You see it? This? So the aim of that to reduce the blood loss when we do the excision. So now we decide to close the uterus with the placenta in situ. Now we close the uterus in layers. We do usually 2 layers when we close the uterus. So, yeah. So just now we close the, the midline incision. So now we look at we try now to separate the uterovesical peritoneum. Try to separate the bladder actually from the uterus. So and it's really hard, this dissection, but with the experience, our surgeons. So and then if you see this here, the clips, so we try not to use if there is any bleeding, we don't use cautery, we don't use anything, we use the clips here close to the bladder, not to cause any hemostasis at bridging vessels here between the uterus and the bladder, and try not to use cautery or anything. We use just the Liga clips. If you see this here instrument, is we just put the clips and to stop the bleeding. If you see how gross is this vessels, so, and we try with this catheter, so actually to reduce the bleeding. Let's say we are not in the UK, we are in Syria or any place, we don't have this, usually in our center we use aorta occlusion. So the intervention radiologist can do that and reduce the blood loss while we are doing the procedure. But let's say we are not in this country, what we can do, we can use this catheter actually, and we reflect the bladder carefully And after that, after we reflect the bladder, you see here, we see the the placenta. We can see here the placenta actually here. So now we finish with the, reflecting the bladder.
Anas, what is the name of the surgeon?
It's one of the, the doctorate with me in the, if you see Miss Bologa and Miss Otekba. Miss Bologa is the one of the consultants in our center. She's originally from Romania, and she's a consultant in fetal medicine. And Miss Otekba is the lead of the fetal medicine, and I was helping them in the in the operation.
Amazing women.
Yeah. So strong women actually. And Miss Bologa learned from Miss Otikba, and now she is the lead actually for the placenta creta. You know all the techniques, how we deal, you know how we resect here. So the UV utero vesicle fold here. So it's really hard until we go here, and then we put the second Jaco catheter. You see the catheter? You see the catheter?
Yes.
We put the second one, just in case. I said, in case of emergency, what you can do. So what we can do, then we can use it. We can use it to reduce the blood loss. Actually, it was supposed to introduce this in the FMF World Congress, but I decided to start with the course by Dr. Verenga. So because I think it's very important to our countries in Asia or in Africa, where I'm originally from Syria. So we don't have this opportunity to have, all this equipment, all this team. Then we can use this kind of, catheter to reduce the blood loss until we resect. We see here. So now I asked her what we will do. She said we will do the resection of this part. So, and you see here when we will resect. Excision of the placenta and part of the uterine wall. So you see now we start with a cautery here. So we didn't use a Caesar. So, and then we see here the placenta now with the umbilical cord close to the base when we cut it. And then we start to cut the uterine wall with the placenta. You see here the bleeding?
Yes.
It's all none. almost not bleeding because of the maneuver we did. And actually, we use this two Jaco catheter. We ask the anesthetist in the same time to lower the blood pressure of the patients. We give her labetalol to reduce the blood pressure. Okay, give her labetalol IV to reduce the blood pressure while we are doing the maneuver, or while we're doing the procedure. So, and if you see here, bleeding almost none. If you see here, there is no bleeding. So we didn't need to put a Bactrica balloon or anything. And the other technique I want to show you, if you see here, two surgeons doing the closure in the same time, which is the maneuver we use, not just one use the maneuver, I mean the closure, but both of them doing the closure in the same time to meet in the middle. The aim of this to, you know, to make it so close to each other, the both side of the uterus, because if you see here is so thick and from down is so thin, then we need to make it close to each other to do this you know, to make it close to each other. And this is important to both surgeons, then can do the you know, the closure in the same time. Otherwise it will be not symmetric if we do it alone, I mean if with one surgeon. So and we do this on two you know, two layers. And if you see here, almost no bleeding. So it will be some bleeding, but you will be surprised how much was the bleeding. So it was not so much bleeding. Yeah, the results was very good here. Closure the uterus with a continuous second layer. So we did here continuous second layer. And you don't imagine, cannot imagine how many people were around us. As Dr. Slaviana mentioned, how many people in the room, is maybe 20 person in the room, you know, between the anesthetist and the second anesthetist and midwives, nurses, medical photographer. We were, I mean, we want to show the people who don't have this, you know, center, how can we deal with that. Actually, we participate in this case and other case in the Royal College World Congress 2022-23 in London, with two cases, one of them this case. So but as you see, how was the results? Is very good results, and especially if the patient decline the hysterectomy and want to preserve her uterus. So which many women want that, not just because of the, you know, children, but because emotional, they feel better if they have their uterus. And we see here the closure almost finished the video. Actually, I'll just show you the hemostasis. So we looked at it here, everything looks fine. So no bleeding, is just some.
Thomas, may I ask you how many cases do you have per year with placenta per crete?
Yeah, I will just answer you. If you see, Dr. Slaviana, I just show you this here. So if you see here, what we are doing here, we try to suture the uterine artery.
Yes.
So ligate the uterine artery in the side, yeah. So you see here is we just do it in the both sides. So you see, we check here bilateral ligation of uterine artery. So this is just to be sure there will not be bleeding. So when one side and the other side. So actually, Dr. Slaviana, we have until now 83 patients with placenta creta. For example, last year, maybe let's say 7 or 8. So every year, because we have fetal medicine center that just we do now the ligation of the other side, and we remove the catheter. But we have almost from 2000, I think, we have 83 patients in total placenta creta. So yeah, and we do here the ligation, the hemostasis with the Liga clips. Almost done, and the patient wants sterilization, and then we will do the sterilization as well. So yeah, back to your question, it's a good center because they have here okay, this extra box stitch applied to achieve hemostasis. So just to be sure, so we have many maneuver to deal with the placenta creta, but I mean I choose this method because I think many people around the world want to know how can we preserve the uterus. So if the placenta creta, unfortunately on the posterior wall, there is no other way, just we do the hysterectomy. But if it is on the anterior wall, and we are sure after we do the MDT with the interventional radiology, anesthetist, and urology, and obstetrician. So then we will decide what kind of procedure we will do. So actually, this I mean, the approach of MDT is very important because all people will be around us. If need any help, they will be around and they will help us. So sometimes we do the stent for the ureter before we start. So the urologist will start with the stent, do the cystoscopy, do the stent, put the stent actually, and then we will start our operation. And maybe before we start, finish the video. So before we start, the intervention radiologist will do the closure of the aorta. And this closure has a good maneuver. Actually, it is intermittent closure of the uterine of the aorta with a balloon. And this balloon we can open and close during the operation. And then we can say now you can open the balloon, now close the balloon with the interventional radiology. We work together with the interventional radiology. But here we didn't need anything actually. No urologist, no intervention radiologist, just we do it on our own. So and this is the steps I told you the stepwise method of pre-op ultrasound placenta mapping. We check with the ultrasound first and recognizing feature of PSD and avoiding the area by applying a fundal incision, delivering the baby and closing the incision with the placenta in situ, followed by applying vaso-occlusive technique, which I told you about the JACO catheter, before proceeding or waiting for help in an emergency, and contribute to reducing maternal morbidity. Is this the same as I told you? This is the steps I explained to you. So we did as well a Robinson drainage inserted. Sometimes we bring the omentum placed in between the posterior wall of the bladder and the uterus, just to reduce, the bleeding. So we suture we put the omentum, placed between the posterior wall of the bladder and the uterus. This is very important. If we think the bleeding, we are not so, satisfied with the bleeding, but in this case, we didn't need it actually. The EBL, the blood loss was just 800 milliliter. We expect more. And hemoglobin was 95. Drain was 50 milliliter. The patient afterwards feels well. Good urine output, and catheter stay for 10 days. And we did the cystoscopy afterwards and was fine. Suture were removed on 21st of September. And patient was discharged home with a good clinical situation. So thank you for your attention. And this is the lead of our center, Ms. Otikba. She's originally from Nigeria, and she organized and established this placenta Accreta Center. Ms. Boroga, the other surgeon, I don't have a picture, but I will make sure that I have a picture next time. And then we have a good team actually in Romford who can give the service for this area, Essex and east of London. Thank you for your attention, and I'm happy if you have any question.
Thank you, Dr. Alojai, for the insightful presentation. We'll take all the questions at the end of the session. Those who have questions, please kindly use the chat box, and we are going to take them at the end of the session. At this moment, there's a slight change in our program. Dr. Verenga will not be able to present at the moment. He was supposed to present on bilobed placenta and vasa previa. So I'm going to take over and present on placenta pathologies in twin pregnancies. So it's quite a short presentation, and I hope to be done by lunchtime. Okay, can you see my screen, somebody?
Yes.
Okay, that's fine. Okay, so I'm going to present on placenta pathologies in twins. As I mentioned earlier on, I'm Dr. Memory Ndagurwa, currently working at Salimu Gabe Central Hospital as a specialist obstetrician and gynecologist, and I'm also a fetal medicine fellow. I'm going to cover placental disorders in multiple pregnancies, is concentrating on monochorionic pregnancies, and we are going to go through twin anemia, polycythemia sequence, selective fetal growth restriction, twin-to-twin transfusion syndrome, and I'm not going to cover placenta previa because Dr. Verenga has already talked about that. for monochorionic pregnancies, it is important for us to know that are sharing the same placenta. The placenta size is important and determines the fetal growth of each twin. The placental territory that is allocated for each twin determines the fetal growth of that twin. And the placenta is divided at the vascular equator. So it is at that division where we see the venous retain, the watershed zone, where we see the venous retain and the veins will be taking up and returning to the umbilical cord. So we don't use the position of insertion of the T sign, but we use the watershed zone, which is referred to as the vascular equator, for determining the division between the placental territories. So in monochorionic pregnancies, at that point, the vascular equator, we have multiple vascular anastomosis, which may be arterial, arteriovenous, and also veno-venous. So the connections that we find at the vascular equator, they determine the outcome of that pregnancy, and they also determine the type of complications that we are going to see in that pregnancy. So the different fetal-fetal transfusion disorders that arise from the connections that are seen at the vascular equator include twin anemia polycythemia sequence, twin-to-twin transfusion syndrome, and I'm going to start off by looking at twin anemia polycythemia sequence. This condition affects up to 6% of monochorionic diamniotic pregnancies, and it's a result of unbalanced and chronic slow transfusion of red blood cells from one twin to the other. And this is taking place through very small vascular anastomosis between an artery and a vein. And these are very small vessels, less than 1 millimeter in diameter. So this can arise spontaneously in about 5% of the cases, and it usually starts after 26 gestational age. It can also arise post-laser ablation for twin-to-twin transfusion syndrome, and this occurs in about 2 to 10% of the pregnancies post-laser ablation. The problem in this condition is mainly a discordance in the hemoglobin count. The twin who is losing blood becomes the donor twin, and the twin who is receiving blood becomes the recipient twin. Like what is illustrated in this image, the main problem is the transfer of red blood cells from one fetus to the other. And in the end, we end up having an anemic fetus and also a polycythemic fetus. This does not affect the amniotic fluid volume in both fetuses. As we can see in this little image on the right side, we have normal amniotic fluid volumes in both sexes, and we have one baby who is looking whitish and another baby who's looking red, and this is the donor twin and this one is the recipient twin. On ultrasound scan, what we can see in the donor fetus is increased peak systolic velocity on the middle cerebral artery, and the increase is more than 1.5 multiples of the median. We can also pick a dilated heart, tricuspid regurgitation, and also ascites. All these are coming up because of severe anemia in the donor fetus. Whereas in the recipient fetus, we have increased hemoglobin count, which will cause the blood flow sluggish. Hence, we are going to have a decreased peak systolic velocity in the middle cerebral artery, and it's going to be decreased by about 1 multiple of the normal median. The recipient, in the recipient, we can also pick a starry sky pattern in the liver, which is mainly due to decreased echogenicity of the liver parenchyma and increased brightness of the portal venule walls. So before 26 weeks, if we diagnose TEPS, the best option would be to do endoscopic laser ablation of the communicating placental vessels, and thereafter, there's need for monitoring the fetal growth, the anatomy of the brain, and the peak systolic velocity of the middle cerebral artery almost every week. If MRI scan is available, it's good to do a brain scan after 32 weeks so as to diagnose any neuronal migration disorders. And if both babies are stable, vaginal delivery is possible after excluding all other obstetric issues at 37 weeks. If the problem is peaked between 26 and 30 weeks, intrauterine blood transfusion to the anemic twin and exchange transfusion with Hartmann's solution for the polycythemic twin should be done. And thereafter, they need monitoring every 2 to 3 days, as the plan of management can change depending on the well-being of the two fetuses. In this case, delivery by cesarean section should be performed at 30 to 32 weeks. However, if the problem is peaked after 30 weeks, it's good to do a cesarean section and to get rid of all the problems and manage the babies in the neonatal unit. The prognosis for TEPS is good if it is managed on time. However, there's a high risk of neurodevelopmental delay in up to 20% of the cases, depending on the time of gestational age. And this risk is higher for the recipient twin. Now we'll move on to a slightly different condition, which is selective fetal growth restriction. This is also a complication that occurs in monochorionic pregnancies, and it affects up to about 15% of these pregnancies. It arises mainly from unequal sharing of the placenta or filamentous insertion of the cord. For unequal sharing of the placenta, I have a diagram on my right side here, where we have one placental mass. On that one mass, we have the first cord on my right inserting almost at the center of the placental mass. And we have another umbilical cord inserting at the little corner in the periphery of the mass. Like what I alluded to earlier on, the territory that is available for each twin determines that twin's fetal growth. So in this case, we have this twin on the left side who is occupying about it, and the cord is occupying about a third of the placental mass. So it means this twin is not getting enough oxygen and nutrients as compared to the twin on my right side who has a large placental mass. So we diagnose selective fetal growth restriction on ultrasound scan if the estimated fetal weight of one of the babies is less than the 10th centile for the gestational age, or if there is a discordance of more than 25% between the estimated fetal weights of the fetuses, or if there is abnormal Doppler studies in one of the fetuses. It is important to note that the amniotic fluid in the small fetus may be reduced, but that for the normal fetus remains normal. In this, it is the typical fetal growth restriction. We may have selective fetal growth restriction with superimposed twin-to-twin transfusion syndrome, where we'll start to see an increased amniotic volume in the bigger twin. we can, for the purposes of management, we can stage selective fetal growth restriction according to the Doppler findings of the smaller twin. So if the baby is just small and the Doppler studies are normal, it's type 1. But if the Doppler studies of the umbilical artery become abnormal, it becomes type 2, and in type 3, the findings may actually be cyclical from normal to absent flow and diastolic flow to reverse and diastolic flow in the umbilical artery of the smaller twin. Okay, I've already mentioned that we can have this condition with superimposed twin-to-twin transfusion syndrome if we start to notice polyhydramnios in the bigger twin. So for selective fetal growth restriction without twin-to-twin transfusion syndrome, that's what I'm going to talk about this afternoon. We continue monitoring growth and amniotic fluid volume and the Doppler studies as well. And the gestational age at delivery will depend on the stability of both fetuses. If both of them remain normal, we aim for about 34 to 35 weeks, where we recommend delivery by elective cesarean section. In this case of selective fetal growth restriction without twin-to-twin transfusion syndrome, the outcomes are very good and survival is about 95% for both twins. Okay, I'll move on to twin-to-twin transfusion syndrome. Of course, it's a multifactorial disorder affecting about 15% of monochorionic diamniotic pregnancies. The pathogenesis remains poorly understood, but it is mainly attributed to anastomosis between blood vessels from the donor twin and that of the recipient twin. And these anastomosis are mainly artery to vein, and they will end up being a difference in the pressure gradient from the artery and the vein, and then blood will end up flowing from the artery to the vein. The twin who is on the arterial side becomes the donor. The twin who is on the venous side becomes the recipient. In this case, the problem is to do with volume. We have a central connection that is of probably normal blood vessels, and there's significant and progressive loss of blood volume from the donor twin to the recipient twin. Like what is shown in this image, we can see that the donor twin will end up having less plasma volume as compared to the recipient twin who end up having hypervolemia, as compared to twin arterial to twin anemia polycythemia sequence, where we have a difference in the hemoglobin count, but the same plasma volumes. So in this case, the donor twin will have less circulatory volume, and less fluid will be filtered at the level of the kidneys, will end up having less urine production and oligohydramnios, and if this continues unchecked, we may end up having anhydramnios in the sake of the donor twin. Because of the reduced amniotic fluid volume, we end up having disturbances in the development of the bladder, urinary system, the respiratory system, the GIT, and the cardiovascular system as well. And this baby will be growth restricted with a discordance in the estimated fetal weight that can get even up to more than 25%. Because of the circulatory insufficiency, we end up having cardiovascular dysfunction, and this places the donor twin at an increased risk of dying in utero. For the recipient twin, we have progressive increase in the blood volume, and there will be more fluid being filtered at the kidneys. Hence, the bladder will be filling even more, and more urine will be produced, which will then result in polyhydramnios. These polyhydramnios can cause lots of discomfort for the mother, and the hypervolemia in the baby can cause hypertension and circulatory overload that then strains the cardiac muscle, and this leads to function failure and fetal demise in about 90 to 100% of the fetuses. Twin-to-twin transfusion syndrome can be picked early on between 11 and 14 weeks. At this point, we are looking at the discordance in the size of the amniotic fluid sacs. And we are also looking at the discordance in the fetal nuchal translucence thickness of greater or equal to 20%. One of the twins can have absent or reversed end diastolic flow in the ductus venosus, and this is usually the twin with the thicker nuchal translucency. After 15 weeks, it's a bit easier to pick twin-to-twin transfusion syndrome, because in this case, we are just looking at the differences in the amniotic fluid volumes in the donor twin and the recipient twin. Donor twin will be having oligohydramnios, and the recipient twin will have polyhydramnios. Of course, the cutoff limits for polyhydramnios are different for the gestational ages. Up to 17 weeks, we use greater or equal to 6 centimeters, and up to from 18 to 20 weeks, we use about 8 centimeters, and after 20 weeks, we use 10 centimeters. Twin-to-twin transfusion syndrome can be staged using the finding of the umbilical artery of both fetuses and also the ductus venosus. For stage 1, everything is still okay. The donor bladder is visible. The Doppler studies are normal. For stage 2, the donor bladder is no longer visible because we said they are not producing enough urine. In this case, the Doppler findings are still within normal limits. However, at stage 3, we have abnormal Doppler studies in either the donor or the recipient. In stage 4, we have fetal hydrops or death of one of the babies. For twin-to-twin transfusion syndrome, the most important tool in investigating this condition is ultrasound scan, which will also be used for surveillance as well. So once we pick the condition, we follow them up every week, we're using ultrasound scan to assess growth, amniotic fluid, and the Doppler studies of the umbilical artery, midcerebral artery, and ductus venosus of both fetuses. There is a first stage where we can just pick a discordance in amniotic fluid volume, but it's not bad enough to be to fit the criteria for the oligohydramnios polyhydramnios sequence. In this case, we just have a discordance, but it does not fit into the oligohydramnios polyhydramnios sequence. If we are at this stage, the survival rate is good. More than 95% of both babies survive. However, the condition can actually progress to twin-to-twin transfusion syndrome in about 15%. Because of that, such a pregnancy will need to be monitored every 2 weeks and to follow up on the evolution of the condition. If we are at stage 1, where we said the donor bladder is stable and the Doppler studies are normal, the survival rate for both fetuses is about 85%, and for at least one twin is 90%. However, this condition can progress to stages 2 to 4 or 20% of the cases. This stage needs monitoring with ultrasound scan for growth, amniotic fluid, and Doppler studies. If there is progression to stages 2 and 4, it's advisable to do endoscopic laser ablation of the communicating vessels. For stages 2 and 4, it depends on when the condition was peaked. If it was peaked before 28 weeks, laser ablation of the communicating placental vessels will also help. And if it's peaked after 28 weeks, it's better to deliver by cesarean section. And of course, the timing will depend on Doppler findings of both twins. And this will help us to plan on the most appropriate timing for delivery by cesarean section. For the survival rates, for stage 2, it's quite good. The overall survival rate is about 75%, and for at least one baby, it's 85%. For stages 3 and 4, the overall survival rate is 60 to 70%, and survival of at least one twin is up to 85%. However, these babies are at risk of neurodevelopmental impairment, and this can affect up to 10% of the babies. So post-endoscopic laser, the pregnancy needs to be followed up, of course, using ultrasound scan every week until the symptoms and signs have resolved and the Dopplers have normalized. And thereafter, we follow the pregnancy after every 2 weeks. And of course, it's also good to assess for brain damage. In the follow-up, it's important to assess for recurrence of twin-to-twin transfusion syndrome and development of TEPS. After laser, the symptoms are expected to resolve gradually, and we start off with the amniotic fluid normalization, which can occur up to 1 week after the procedure, and the cardiac dysfunction may take up to 3 to 4 weeks, and there's a complication of amputation due to thrombotic events or amniotic bends, which can occur in 1 in 1,000 cases post-laser. If the baby is stable and all the obstetric issues are in control, the pregnancy can be delivered vaginally at 37 weeks. Thank you. So at this juncture, we are going to get questions for my presentation and that of Dr. Slaviana and Dr. Alojai. Okay, someone was asking how they can join the fetal medicine unit Zimbabwe. It's Imwango. You put your email address, our secretary is going to get in touch with you. Okay, do we have questions for Dr. Slaviana or Dr. Alojai or myself? Dr. Verenga?
Hello, yes, Dr. Naguro. I wanted to ask both Dr. Slavian and Dr. Alojaili, how best we can screen for placenta accreta spectrum or the PAS spectrum in low resource settings. Because in this meeting of obstetricians, fetal medicine specialists, sonographers, radiographers, what is the best strategy that we can employ to screen for these conditions so that we can convene the MDTs, we can also have 20 people in theater? Well, sometimes they are picked incidentally when people are already in theater.
I think before the screening should be the prevention. And this is very difficult everywhere in the world to reduce the rate of C-sections and therefore the placenta percreta spectrum as well. But in the low resource settings, without ultrasound, I don't think there is a chance to screen for placenta percreta. And what I know from Samira, for example, what they do if they don't know that it is placenta percreta and suddenly the team finds out during the delivery while they are doing a C-section, if there is no bleeding, what they do is they will stop the C-section. They are not going to do any further operation without an experienced team. Even they can close the abdomen and send the patient to a placenta percreta center. But this is, of course, Austria, where they have helicopters, where they can move the patient. Everything is very easily done. I don't know if I can find the solution without resources. You need people, you need machines, you need blood, you need medications. Many people are involved in the treatment of placenta percreta. I don't know if you have answer, Claudius.
If I can say something about that, because I'm in the placenta creator center. First of all, establish a placenta creator unit in the fetal medicine unit. And this is a placenta creator, screening. For example, if any of your colleagues has any suspicious of placenta creator, then they send to the center, which is in Harare, and you establish the that's what we have done in Romford. Establish a team, surgeon, at least 2 surgeons. If surgeon not available, the other surgeon will be around, and 1 anesthetist has good experience, and 1 urologist, and 1 radiologist or intervention radiologist, if you have in your country intervention radiologist. And then if you have any suspicious, then an MRI should be done after the ultrasound. If you do the ultrasound and you have suspicious, then an MRI should be done. After we have all the results, if we have patients with 2 or 3 cesarean section or 1 cesarean section, and we have suspicious of placenta accreta spectrum, then we meet in a day and decide what's the best course of action. Any suspicious of a placenta accreta or going to the bladder or pericreta, then the urologist will start first, and the urologist will do the stent, and before we do anything with the placenta or the delivery. So for both ureter and the anesthetist will do his part with the reduction of the blood pressure during the operation. And the radiologist will give us his experience about MRI if there is really suspicious of pericrata. And intervention radiologist, his job is to do the aorta balloon if it is possible there, but I think it's not possible. And even though in UK not every hospital has people who have experience with aorta balloon. But as I show you, this Jaco catheter will help a lot. So to reduce the blood loss. And the other patient, the other contributor is the hematologist, which is one of the most important people who will help us to be prepared for the blood if we need it during the procedure, which high likely we will need blood during the operation. And after that, I think after you establish this team, so then you will see the referral. And by the time when you establish this, you put the criteria for the referral. So for example, previous cesarean section, any operation on the uterus, for example, any miscarriage with a surgical intervention. So kind of things, a criteria for the referral. And afterwards, by the time you will have the experience, after you see, in many, let's say, cases, and if you need any help, for example, let's say, any case, you can send us the case. I'll present it to my lead, and then we will give you the advice. What's the next? What's our opinion about that? So it's kind of multidisciplinary team is the key actually to deal with this kind of high risk patients. MDT, it will help a lot. And after MDT in 2015 actually, so we had a case with the patient was, died because of sepsis, before 2015. But after the MDT approach, there was no any kind of complication like death or something like that. So either hysterectomy or excision of the anterior uterine wall. So, and all cases had good results. This is my opinion actually for the establish placenta creator unit in the fetal medicine department. So that's what I think it will help a lot. By the time you will have a good experience, and if you need any help, we are more than happy to help. Thank you.
Thank you so much to both Anas and Slaviana. Your response, I think, probably is the way to go, because I feel there's also need for training, and establishment of this unit will help us to develop a training platform for better assessment of the utero-placenta interface for suspected cases. So very valuable answer to this question. Thank you so much.
I'm happy. Thank you, Dr. Varenga. I'm happy to participate in the next time or the next, let's say, meeting next year. If you need any help, I'm happy to come to Zimbabwe as well and give my experience, both in ultrasound and operation. And in the future, I will provide you with some cases, videos. It will help actually the surgeon as well there.
Excellent. Thank you. Thank you so much. I think it's time for lunch. Thank you so much to our presenters. Like we said, Dr. Slaviana is in Zimbabwe in person. She has already interacted with a number of colleagues and she has been on the ground. It has been a pleasure having her here in Zimbabwe. And to the rest of the colleagues who are not from Zimbabwe, you are more than welcome to visit us and to strengthen us, and we'll be more than happy to come to where you are as well. So yeah, so let's go for lunch, and lunch will be up to 11:40. Then Mr. Zanga, to 1:40, sorry, to 13:40, to just compensate for 7 parts. We'll give you 30 minutes of lunch. 13:40 should be able to proceed, and we'll try to finish on time. So do not think that will keep you longer than we're already committed to. Otherwise, I wish you a fruitful afternoon again as you come back after lunch. Bye-bye.
Thank you. Bye-bye.
Thank you.
Thank you very much.
Good afternoon. Good afternoon, everyone. We're just sorting out a few technical issues. Just bear with us. Hello. Yeah, I think we are now sorted. So I'll be your captain for this afternoon session, last session for the day, whereby we have 3 presentations lined up. So there is a slight change in our program. For those who were with us earlier on, Dr. Ndagurwa already presented before lunch, so she is no longer part of the afternoon panel. So without further ado, I'll be your host for this session, and I'll also be the presenter. My job is an easy one, as most of the things have already been said or touched by earlier presenters. So I'll be taking you through preeclampsia and placenta pathologies. My name is Admaya Sanga. I'm a specialist fetal sonographer. Just to preach to the converted, I'll just recap what preeclampsia is, which is de novo gestational hypertension after 20 weeks of gestation, which is accompanied by proteinuria, as well as they can be, or sometimes they can't, they will not be maternal liver or kidney or hematological disease. So preeclampsia is a major contributor to the maternal and neonatal mortality and morbidity globally. It is the second largest cause of maternal mortality worldwide and affects 5 to 7% of pregnant women globally. As you are aware, preeclampsia is divided into early onset and late onset, with the discriminator being 34 weeks. It occurs before 34 weeks, it's referred as early onset. If it occurs after 34 weeks, then it's referred to as late onset. So in early onset preeclampsia, it has some typical features, which include, I'll also touch this in the next slides in a bit greater detail. There will be inadequate and incomplete trophoblast invasion of the maternal spiral arteries, and there will be changes of the blood flow within the placental bed spiral arteries, and this can be depicted through high uterine artery PI So there'll be high resistance within the uterine arteries. They become sort of stiff, and the floor can be with or without notching. There'll also be an increased peripheral resistance of placental vessels. So they'll be depicted through high umbilical artery PI, which will have decreased end-diastolic flow. It can be absent, and in most cases, there will be reversed flow during diastole, and there'll be kind of fetal growth restriction. Then the side of what late onset preeclampsia, which contributes of 4/5 of all preeclampsia cases globally. And some of the typical features include they can be a normally growing baby with no signs of any growth restriction. A normal or slightly altered behavior can be exhibited in the uterine spiral arteries, and these can be seen by there being some slight changes in the uterine artery PI, a slight increase in the resistance, or there can be no change. Then there will also be no changes in the blood flow of the umbilical arteries, so they will be having normal PI values, and there'll be risk for enlarged placental mass. I think this was touched on earlier on. In cases of diabetes, multiple pregnancies, anemia, in high altitude. The pathophysiology of preeclampsia, the events can be grouped into adaptation of immune response to pregnancy, which those effects and findings, which include inadequate extravillous trophoblast migration, chronic chronic chorioamnitis. Then there can also be inadequate extravillous migration, manifesting as unconverted placental bed spiral arteries, increased multinucleate trophoblast cells in the basal plate. And one of the key pathophysiological event is intrauterine hypoxia, which will manifest through persistent villus cytotrophoblast, presence of fetal nucleated red blood cells in villus vessels, chorioamnitis. It was touched on earlier on. So I'll just take you through the normal versus the preeclamptic pregnant woman. So in the normal, the maternal spiral arteries will appear normal, whilst in the preeclamptic pregnant woman, there'll be abnormal spiral arteries remodeling. Then there will be normal cytotrophoblast invasion in the normal pregnant mother, whilst in the preeclamptic pregnant woman, there will be reduced cytotrophoblast invasion and proliferation. Then there will be normal oxygenation in the normal pregnant mother, but in the preeclamptic pregnant woman, there will be placental hypoxia. No resistance to blood flow in the normal versus placental ischemia and increased oxidative stress in the preeclamptic pregnant woman. Then there will be increased blood flow in the normal versus decreased blood flow in the preeclamptic mother. So what will be the consequences? In the normal pregnant woman, there will be no more angiogenesis because there will be more of the placental growth factor in comparison to the soluble globulin as well as the S-FLT1. whilst there's, you can see on the scale there that in pre-eclamptic pregnant women, there's a tipping of those hormones, the soluble endocrine as well as the athlete one, they increase. And these ones are anti-angiogenic factor hormones, and there'll be a decrease in the placental growth factors. This is further depicted in the next diagram, as you can see here. So in the non-pregnancy, you can see that the nutrients, the pressure, the oxygen, they are normal, and the pro-angiogenic factors, which include the vascular endothelial growth factor, the placental growth factor, as well as the angiopoietins are all normal. And you can see that the anti-angiogenic factors, the S-fleet and the soluble endocrine, they are decreased. And this will result in normal vessel formation, as well as normal fetal growth. However, when we've got an increase in the S-fleet and soluble endocrine, there is increase in the antioxidants as well as the oxidative stress, which can result in abnormal vessel formation and resulting in reduced growth. Then you can see on the last part that there is now inflammation, apoptosis, necrosis, and the rate of oxidative stress is also increasing, resulting in abnormal vessel formation as well as reduced fetal growth. This next diagram is just showing us the normal versus the ischemic representation of what will be happening. You can see here during remodeling, the remodeled artery, you can see it's wider, and you can see the villi, they are more, and you can see by the presentation of the villus trophoblast, the Hofbauer cell, and the villus endothelium. Whilst on the ischemic one, there is now syncytial knotting as well as fibrin deposition, and it results in stiffness of these vessels, and it will have an impact on the flow of blood through the placenta. I think some of these ultrasound images have already been discussed earlier on. The first one is just showing ischemia. You can see the ischemia there. Then this one is a hematoma. And this one are some calcifications, which will inform our next table, which I'll be discussing a study which was done by Zeiwe et al. In Nigeria. It's a study which was conducted here in Africa, whereby they were looking at placental peripartum pathologies in women with preeclampsia and eclampsia. And it constituted 61 cases, and of the 61 cases, 53 of them had preeclampsia, and 8 of them had eclampsia. And the control group comprised of 122 normal pregnancies. So in this study, this is a snippet of some of the results. So you can see as far as infarction, if it was between 0 to 5%, according to the p-values at the end there, they were all statistically significant for the mild preeclampsia, the severe preeclampsia, as well as the eclampsia. Okay, I'm hearing my screen is not coming. Let me just sort out that. All right, so I'll continue. I hope you're seeing the screen, which is showing us the results of the Ezeigwe et al. Study conducted in Nigeria. Where I said they had 61 cases, as well as 122 controls. And the 61 cases were 53 women which had preeclampsia, and 8 which had eclampsia, and 22 controls. So I was now elaborating on the result of the infection, which if they were between 0 and 5%, they were statistically significant for the mild, severe, as well as the eclampsia, with p-values of 0.02, less than 0.001 for the severe preeclampsia as well as the eclampsia. Then, if you look at the second highlighted row of 11 to 20% infection, there was no statistical significance in the mild preeclampsia, but it was exhibited in the severe preeclampsia as well as the eclampsia. Then if they're greater than 20% infects, they were not statistically significant again for the mild, but they were statistically significant for the severe preeclampsia as well as the eclampsia, with p-values of 0.001 and less than 0.001 respectively. Then when they looked at hematoma, if the hematoma was absent in the 3 groups, the statistical significance was there for all 3 with respective values of 0.009, less than 0.001, and less than 0.001 for the severe and eclamptic groups. Then if it was present with 2 pluses, it was statistically significant for the severe preeclampsia and the eclampsia group, but no statistical significance on the mild preeclampsia. Then finally, if you look at the calcifications, if they were absent or if they were just 1 plus, there was no statistical significance. But if there were 2 pluses, they were statistically significant for the mild preeclampsia with a p-value of 0.001. No statistical significance for the severe, and also no statistical significance for the eclamptic group. So these are the gross placental changes. Now I move on to the histological findings. So as far as the histological findings, we've got stromal edema. I think some of these were talked in detail earlier on by the pathologist. We've got stromal edema, stromal fibrosis, syncytial nodes, retrotrophoblastic proliferation, accelerated villus macula, as well as decidual arteriopathy. So in the 3 groups, you can see the p-values at the on the column at the right, on the right side, and you can see the ones which are underlined are the ones which were statistically significant. So for cytotrophoblastic proliferation, it was statistically significant for the 28, contributing 71.8%, with a p-value of 0.001, as well as for the eclamptic group, 6 contributing 0.001. Then for the accelerated villus maturation, it was statistically significant again for the pre-eclamptic and the eclamptic groups with p-values of 0.01. Then for decidual arteriopathy, it was statistically significant, the manifestation in the eclamptic as well as the severe pre-eclamptic groups with respective p-values of 0.01. So what's the take-home message? We are trying locally to come up with sort of our own sample locally, whereby in the private sector, the process has started of sending some of the placentas that would have been flagged to have some placental lesions during ultrasound scan evaluation in these pre-eclamptic mothers, and they are being sent to the laboratory. It's still in the early stages, but I think with the process of time, we believe we're going to have a very good sample of these placentas to also have the data analyzed to see if there are any variances, probably with the Nigerian study or any other studies. However, there is need for collaboration between the obstetricians and the pathologists in studying more placentas with lesions. I think the pathologist earlier on highlighted that it doesn't cost much, but it might be worthwhile sending these placentas for further scrutiny. However, there's need for a consensus on the critical aspects that need to be included in the histological report so that the different cases won't have the same histological report outcome. Thank you. That concludes my presentation. I would like to acknowledge the Fetal Medicine Foundation Zimbabwe, the Fetal Medicine Unit team, teams at Salem Gabe and Parinyatwa, as well as the Fetal Clinic. And those are my references. So that concludes my talk. Thank you. Okay, so as the captain, I'll just take a breather. I just take a glass of water before I introduce the next presenter. Right, so moving on, we're going to have our next presentation, which will be taking us a journey through placenta pathologies in FGR fetuses. And to do that, We've got Dr. Tsate, who is one of our new interns who has shown interest in fetal medicine and did a short stint in the fetal medicine unit before starting his internship. He just finished his undergraduate degree in medicine at the University of Zimbabwe. So he will be taking us through the journey of placental pathologies in FGR fetuses. Over to you, Dr. Rizate.
Thank you very much, Mr. Zanga. Just confirm you can hear me and you can see my slides.
Yes, we can.
Okay, thank you. Yeah, now they can hear me. So I'm going to present on placenta histopathologies associated with FGR. These are pathologies that show an underlying chronic undersupply of oxygen and nutrients to the fetus. Now, some of you may know him, some of you may not. I think most of you know him. Anyway, this is Elvis Presley. Elvis Presley is arguably the most famous FGR baby. In a paper prepared for New Zealand and Australian cardiologists by a British epidemiologist, he noted the king of rock and roll was a prime candidate for heart problems since he was in the womb, judging from the fact that Elvis had a twin when he was born, but unfortunately the twin didn't make it. And Elvis was the donor twin in a twin-to-twin transfusion syndrome. And being the donor twin, this left him vulnerable to SGA, and it left him small for gestational age. Oh, sorry, give me a second. And being small for gestational age, this left him vulnerable to many conditions, long-term and short-term. The king of rock and roll did demise to a myocardial infarction due to drug abuse, but still it is an interesting fact. As from literature, we know now that being small for gestational age leaves you vulnerable to many conditions, both short-term in the neonatal period and long-term. In the neonatal period, you're vulnerable to cardiovascular conditions, respiratory conditions, neurological conditions. Among the respiratory conditions, you have increased need for respiratory and ventilatory support. You're more vulnerable to meconium aspiration syndrome, and you find that these babies spend more time in the NICU, putting a stress on the health system. And then in the long run, you find still on the same systems, you find that these babies are more, when they grow up, they are more prone to hypertension, ischemic heart disease, stroke, and in the respiratory system, chronic respiratory insufficiency syndrome and restricted airway disease, and also cerebral palsy, learning difficulties, and dementia. Now, this is classification for the placental pathologies. I've highlighted the sections that we will touch on today. You can see here the placental vascular pathologies who look at mostly, these are the maternal vascular malperfusions, which are divided into early and late. These have already been touched on by Mr. Zanga in his presentation. So all I'll say is these are the ones that we normally encounter, as these are the most common. The majority of placentas following delivery for severe FGR are from maternal vascular malperfusion, and especially with coexistent preeclampsia, these will show maternal vascular malperfusion. These women usually have high uterine artery PIs and is associated with high BPs. Now, the more interesting cases when we move on are the fetal stromal vascular lesions. These are lesions that involve, you will see clinically normal BPs and normal Dopplers except for the umbilical artery Doppler. And this will signify fault in the fetal system. So if you see an abnormality in the umbilical artery Doppler and everything else is normal, that's where your pathology is. And then even more interesting are the placental inflammatory immune processes. these are much harder to diagnose. They will come with normal BPs, normal uterine artery Dopplers, and all you see at times is the small fetus. So moving on, looking closer at the vascular processes. As mentioned before, these are split into early and late. The early are those where the uterine artery abnormalities are diagnosed from the sources I used before 32 weeks of gestation, and the late ones are when the presentation is after 32 weeks of gestation. The later ones are the more milder conditions, which was also mentioned by Professor Nlau in the beginning. So I will not go too deep on it, but I would just want to mention a few things on the pathophysiological features. The pathophysiology is initiated by failed physiologic transformation of the spiral artery branches of the uteroplacental artery. This restricts maternal blood flow into the intervillar space. This state of maternal vascular malperfusion is identified sonographically by the combination of a small placenta and bilateral abnormal uterine artery waveforms. And persistent ischemic reperfusion damages to the developing placental villi, causing the histologic feature of maternal vascular malperfusion, which include multifocal infarction and formation of syncytial knots, which Mr. Zambuko also mentioned. I'll give you an example later in the slide. And then another major disease process in maternal vascular malperfusion is chorion regression. This refers to poor early formation of the definitive placenta at the expense of the membrane. I will talk more on this one later also, as we have an example from one of our cases. And now moving on to the ones I said were more interesting. These are the non-maternal vascular malperfusion placental. So as you could see from the classification I gave you earlier, these are the we have the chronic villositis and the villositis of unknown etiology. And these have similar histological characteristics, but the etiology is different. The villositis of unknown etiology is more of a immune response, and the chronic villositis is more, the villositis of unknown etiology is more of an autoimmune response. While the chorionic villositis is more of an inflammatory response system. So, sorry, let me just start by saying, as mentioned before, significant FGR and associated placental pathologies with non-maternal vascular placental diseases can occur with normal uterine Dopplers and normal BPs, making them hard to diagnose. Starting with chronic histiocytic intervillositis, this affects up to 4.4% of all first-term trimester miscarriages and 0.6% of second and third trimester placenta pathology. Overall recurrence rates can range from anywhere from 67 to 100% without treatment. And affected pregnancies delivered after 22 weeks have a high rate of fetal growth restriction, up to 62%, and stillborn birth up to 46%. And this has been shown to improve with immunosuppressive therapy. And then moving on to the massive perivillous fibrinoid deposition. These are much rarer than estimated incidence of 0.5%. The clinical correlates of MPFD include poor obstetrical history with losses usually in the second trimester and third trimester, intrauterine growth restriction, intrauterine fetal demise, live birth with development of neural disabilities. Although massive perivenous fibrinoid deposition is often associated with catastrophic pregnancy complications, new research and new intervention have been shown to improve outcomes. And then moving on to the villositis of unknown etiology and the chronic villositis, these remain under-recognized and underappreciated lesion by both pathologists and obstetricians. I think Dr. Zambuko also mentioned this earlier on in his slide. And adding to that, the incidence of vilicitis of unknown etiology in most studies ranges from 5 to 15%, the majority occurring in term placenta. And rightly so, most cases are associated with normal term pregnancy and normal newborns. But nevertheless, as we were here in the pathology talk, in low-grade lesions, this is if low-grade lesions are discounted, an association of vilicitis of unknown etiology. Nevertheless, if low-grade lesions are discounted, there's an association of vilicitis of unknown etiology with adverse perinatal outcomes, including intrauterine growth restriction and stillbirth. And the recurrence rate is 10 to 15% and are more common among high-grade cases, especially when the lesion is associated with perivenous fibrosis. And also to add, any of these diagnoses, as you see with their sometimes very high recurrence rates, this will help to inform counseling about recurrence rates and prognosis for mothers. Next slide. Sorry, I'm just having a bit of trouble with my slide. Letting me move to the next one, just give me a second. All right. So now we have our first case. This is a 37-year-old female patient, gravid 5, para 2. Her risk factors were preeclampsia, diabetes, and hypertension. When we saw her, was 25 weeks plus 5, and she had the baby was below the 2nd percentile, and the uterine arteries were abnormal, and the uterine arteries were abnormal, and the umbilical arteries were abnormal, and she had high BPs. And she had to deliver at 26 weeks, and unfortunately, we had a poor outcome as the baby demised after 5 days. But from our charts here, you can see, as I was mentioning before, chorion regression for the maternal vascular malperfusion. Here you have a very round, I don't know if you can see my cursor, you have a very round placenta here. Very round, very thick placenta plates. Normally you expect your placenta to fill out the space, but this, because it's very small, it has a very small surface area, it's receiving blood, and also that blood just pools in the placenta. You find that after delivery, this placenta basically squishes and it becomes very small. Showing that there was a reduction in the surface area for exchange, what leads to the placental insufficiency. And then also here in the top right corner, this is the MCA Doppler. This is a brain sparing effect. You find early on at this gestational age, we don't expect such high flow in the diastolic phase. This is when blood is being shunted from other organs to the brain. Hence the brain sparing effect. And then here in the middle, you have the umbilical Doppler. You see here, this is our baseline. And when it goes below our baseline, this is now reverse flow. You should never have reverse flow at any point. Then our histopathology, which we should also focus on later with other cases and compare. We have an accelerated villus maturation represented by small, thin, elongated villi with increasing central nodes, tiny Parker lesions, basically, cystovillus hypoperfusion. And this is characteristic of maternal vascular malperfusion. Then moving on to our second case, we have a 27-year-old female patient, gravida 3, para 1. She had no risk factors, and at 36 weeks, the fetus was on the 4th percentile on all parameters. You can see here from our charts on the top right. And then she delivered at 37 weeks with a birth weight of 2.3 kgs. And then on histology, she also had terminal villi with increased central noting, the tiny Parker lesions, and widespread cholangiostis in keeping with hypoperfusion and acute cholangitis. So I also want to point to the fact that she had normal Dopplers and normal BPs. And then moving on to our third case, the 37-year-old female, gravida 3, para 2. She had no risk factors also. When she came to us, you can see we saw her 3 times, and all the readings were below the second percentile. And the diagnosis was made in week 25 here at our first visit. And we managed to push the pregnancy up to the 35th week, and birth weight was 1.3 kg. And also, I would like to point to the fact here that, when we look now at the histology, you see increasing spinal nodes and vascular and villus dystrophic calcification and fibrin deposition, which is characteristics of the other non-vascular lesions that we spoke of. And here, when you look at the placenta, the calcifications here showing early maturation, as we wouldn't expect these at this stage. And then now here, we look at a 28-year-old female patient. She came in with, we saw her quite a few times actually, 7 times. Her BPs were normal throughout, and her risk factors were preeclampsia in a previous pregnancy. And you can see that the trend, it gradually deteriorated. At 28 weeks, she had an expected fetal weight. There was an expected fetal weight below the second centile, and placental insufficiency was noted with normal Dopplers and normal BPs. We managed to push delivery. Sorry, I don't know why this is coming. Okay. We managed to push delivery up until 37 weeks, where she gave birth at 2 kgs. In the histopathologic findings, we found focal perivillus fibrin deposition. And then moving on now, and this is one of the lesions that is associated with non-vascular, non-maternal vascular malperfusion diseases. And then now looking at our cases to compare, you can see there's a bit of a trend, but also as mentioned before, there's a bit of discrepancy where we have different clinical features and we expect different lesions, but still we find that we get the same results from the pathologist. Like for here, an example for case 1 and case 2, where we had abnormal BPs and uterine artery Dopplers in the second column. For case 1, the BPs and uterine artery Dopplers were abnormal, and we got the tinea Parker lesions, but also in case 2, where they were where the BPs and uterine artery Dopplers were normal, and we expect features characteristic of non-vascular lesions. Yeah, you find that we found the same lesions as the vascular lesions. But when you now look at case 3 and 4, where the BPs and the uterine artery Dopplers were normal, you find that we are finding now features that are characteristic of the non-vascular lesions that we expect. Here you have your vascular and villus dystrophic calcifications and your fibrin depositions, and the focal perivillus fibrin deposition. The focal perivillus fibrin deposition is not to be confused with the massive perivillus fibrin deposition. This is a milder form of the disease, and the focal perivillus fibrin deposition is more associated with chronic villositis, the one that I said has a recurrence rate of 10 to 15%. So moving on, from our cases, from the cases that we found, we felt that we could do more because we didn't know much about what we could do for the women with non-maternal vascular malperfusion. So we've decided to do a research project where we'll be comparing the placental histopathological findings in vascular and non-vascular mediated fetal growth restriction to help find answers of how we can help these women, and also add to the already established body of research that's there, as this is still building up. And we find that, as Dr. Zambuka had mentioned before, some of these lesions have a very high recurrence rate, up to 67 to 100%, I think I mentioned, for CHI. And there is treatment for some of them. So if we're able to diagnose these conditions, then we can do something for our patient. So we're doing a research project on this, and then we'll see if this is indeed the best way to go about finding these lesions, and if not, how best we can do it. Thank you very much for your time.
Thank you so much, Dr. Rutsate, for the insightful talk, taking us through the journey and the cases of placental pathologies in FGR fetuses. It just demonstrates that these things are not just textbook stuff, but they are actually happening on the ground, and it is imperative that those who are involved in the management of these high-risk pregnancies, that they do the needful in terms of scanning meticulously and including all the necessary documentation which will help in the management of those pregnancies. All right, so we are getting there. If there are any questions, please just continue writing them in the chat box. At the end of the session, we're going to have a discussion which will touch on the presentations after lunch, as well as any other burning issues which were presented even in the morning, as well as in the mid-morning. All right, so without further ado, I want to introduce you to our next presenter. We are operating way ahead of time. So this is our last presenter, and he'll be taking us through placenta pathology and infections. Some of the information would have been shared in other presentations, but we are now zeroing in on infections and placental pathology. And to do that, we've got in the house a senior registrar in the fetal medicine fraternity in Zimbabwe, as well as I think if he doesn't disappoint us, he should also be starting fetal medicine fellowship next year. So I think I've just mentioned that to put pressure on him so that it comes to fruition. So I've got Dr. Chirume. He'll be taking us through placenta pathology and infections. Over to you, Dr. Chirume.
Thank you, Mr. Zanga. I won't disappoint. It's difficult to present after the professor. The afternoon is always difficult, but such is life. We have to deal with it. So I'm going to talk about the placental. So I'll start by presenting a case. I was also involved in management of this case, so I thought I might share with you. She was a 25-year-old pregnant with 2 healthy children at home. She was referred to the unit for the IgM positive for Bella. She wasn't recognized, no chronic illness, and no unusual done. On the far right there, you can see the outcome about calcifications, large placenta. I don't want to waste much of your time there. She had also these features on other systems, but today we are dealing with the placenta, so we are just remaining focusing on the placenta. These are the ultrasound scan features I will skip. We have already dealt with histopathy. Dr. Sambu has done justice, so I'll skip them. So I'll mainly focus on the infection. We are in mode where HIV problem, STIs, then I just touches and COVID just for complete. So these are the infections that I'm going to highlight to you. So we've been educated by coin that with a touch infection, you have a vertical infection to the fetus. But there are a lot of things which up to now we are not aware of. For example, even the absence of congenital infection. Why is it that maternal infections such as malaria or HIV have been linked at birth outcomes such as the low birth weight, birth growth resistance, birth, or even cause of our neonatal death here in Southern Africa? There are no answers. Some of them. And also to say that even despite the wide coverage of antiretroviral drugs, there's been noted that there are higher rates of adverse birth outcomes. So these are some of the questions which I will try to this afternoon. Why is it so that despite the congenital infection, they have higher birth, preterm birth, still birth side of the board, or even at treatment, there's still higher birth outcomes in HIV positive. So to understand and try to answer some of these questions, I'll try to zoom in to the molecular level, right? This will help us to try to understand how we can try to avoid some of these problems we face inside of the world. And also, I've been noted literature that even with a prior infection of a malaria or even an influenza, that there are long-term behavioral changes. I think you might some of our colleagues who are experiencing these behavioral consequences. It might be they had a malaria infection or even a UTI pregnancy and physical function. So I will try to zoom in into the molecular basis so that we try to understand. I think this diagram is clear to you. You can see all these receptors starting from the far left. Right. So if you are to start on my far left there's a receptor, which if you go down, it's called a Tie2. And these B-looking things, they are the vascular endothelial growth factors, the receptors. And if you are to look at these small boxes, as well as the dots, these are the angiopoietin as well as the placental growth factor. So what happens is there should be a balance angiogenesis as well as the anti-angiogenesis, right? Your infection, this is very important to understand because this is where we are going to find our answer. But your pathogens like your HIV or malaria, it doesn't stop the effects, the adverse effects on the outcome, like your preterm death, they don't change even if you treat your HIV, even if you treat your malaria, you still get those adverse outcomes. How do you go about to reduce? By understanding these molecular things there, so that we can do something, try to modify these molecular particles. Besides treating your HIV, besides treating your malaria, you need to modify this immunity so that you avoid this outcome. So if you are to look at this diagram, there should be a balance between the angiogenesis, the vasculogenesis. These are the factors which promote vascular formation, you still remember that we need your vessel to be formed during your placentation. So if you got your VEGF as well as the placenta growth factor and angiotensin 1, they are going to make formation of those vessels. And if you are going to have your soluble, split the soluble one, these ones, you are going to so there should be a balance of these things at molecular level for you to have a normal placenta. So going forward, this academic, I know some people are stimulated when they see these little diagrams. I just put it for completeness sake, and you can see this model has been postulated in malaria. I don't want to waste much of the gigabytes of some of us. I'll just move on. Literature review to be able to support what I've been described by that diagram. It was noted that long back in 2002 by Watson that poor birth outcomes by inflammatory mediated disruption of placenta development function. So it was noted this year that for those babies who had poor outcomes, there was some inflammatory mediated disruption at placenta level. So this also helps us understand that even if you don't find anything on an ultrasound scan finding, these things can still be going on the background, which can affect the outcomes. And also another study which was done by Kido long back, also that vascular development and adaptation were associated with pregnancy outcomes, including eclampsia and small for gestation. What this slide is just telling us is that there is an inflammatory component disturbing these molecular particles, resulting in your adverse outcome. Not necessarily your ultrasound scan features, which you might be looking for, might fail to find anything, yet things are occurring at molecular level. Another study done by Kuma in 2013, this one was more recent, it showed that in examining those placentas, there was some villus architecture and maternal vascular malperfusion in viral or bacterial and placental infection. So which means we still need to go ahead and send those placentas to the pathologist so that at least we can note some of the changes which might help us in the management of our patients. And also domain 2002, you noted that in humans, maternal infection was associated with impaired maternal and fetal hemodynamics. All these studies are just showing that things are occurring at molecular level, so we need to send the specimen for some pathology. So this one, which was done in 2019, what they noted was very interesting in that by using sulfur dioxide and azithromycin, there was an improvement in the birth outcomes. And this has been noted that there was some regulation in the inflammatory, like we have already said that process. Besides just the pathogen, need also to go into the inflammatory markers and try to regulate them. And they noted that with these drugs, there was some improvement the pathogen. So without further wasting time, I'll reach to the conclusion and the recommendation to say that, number one, identification of infection of the placenta is essential when we're investigating those patients with abortions, stillbirth, or growth retardation. These the specimen so that we correctly know what is the underlying cause. And the number two thing is to say that we need research. You can see there's limited data in terms of placenta pathology, in terms of the infection. So we need some future research. What is this research going to do? It's going to focus on the therapeutics to target those placental inflammatory markers, so that besides treating the infection, we would also need to modify those inflammatory markers which are associated with poor outcomes. I think I'll end here for the sake of time, and Over to you, Mr. Zanga.
Thank you so much, Dr. Jerome, for that informative talk. I believe we learned so much, and all the guests took home something. So now the floor is now open for questions on the afternoon presentations, as well as if there are any burning questions from earlier presentations. I think we're just in the last lap of this refresher course. So if you have any question, you can type it in the chat box, and it will be given the necessary responses. Currently, I'm not seeing anything in the chat boxes. Any questions regarding the presentations which have been done to date? Probably I can just take you through what was happening since morning with the presentation on placenta histopathology and common placenta pathologies. We had a talk on ultrasound scan placenta evaluation. Then there was a presentation on the relationship of placenta grade and uterine artery Dopplers. Then there was a double header from the professors. The first one was touching on ischemic placenta diseases and thrombophilia, and the other one was elaborating on placenta tumors and ultrasound examination. Then after the tea break, we had placenta accreta and pecreta. Then we also had placenta pathologies in twins. Then after lunch, we had placenta pathologies in preeclampsia. We also had placenta pathologies in FGR fetuses. And just the last presentation was on placenta pathology and infections. Okay, so I can see one of the comments is saying all the speakers were very well prepared and clear. Great webinar. Thank you for those kind words. Thank you, Prof. Chauke, for taking your time to be with us from your busy schedule. And you are saying thank you, Fetal Medicine Foundation Zimbabwe, for the great refresher. It was a pleasure having you along. So if anything arises, probably we'll address it. But for now, I think it's my honor and privilege to end this session, and I'll hand over for the closing remarks. It being a Saturday, I think most of us would want to have an early day off so that we can rest. So I'll hand over to Dr. Velenga for the closing remarks. Thank you.
Thank you so much, Mr. Zanga. And I would like to take this opportunity to thank everyone from the presenters, our guest presenters from Prof. Nicolau, Prof. Chauke, Dr. Slaviana, and our own presenters, Dr. Ndagura, Dr. Shirumi, Mr. Zangra, and the rest of the team that presented today. Thank you so much for taking time to do this. And I would like to appreciate all of you guys who took your Saturdays to listen to the presentation, to the presentations of the teams. The whole goal here is to try and advance women's health. So we hope that the knowledge you received today will help you to improve how we are doing things, will help you to look at the placenta more carefully, will also help the clinician to think clearly whenever faced with fetal growth issues, the placenta abnormalities. These presentations will be available on the Fetal Medicine Foundation Zoom YouTube channel. So our team, probably in less than 2 weeks, they'll put them on the YouTube channel so you can watch them over and over again. To just let you know that in October, it should be in October, that of course the dates will come out, the poster will come out. We will be hosting the African Congress in Fetal Medicine. So again, invite our honored guests and presenters and more. Probably we have more guys in the, from Europe, America presenting in our meeting at the African Congress, and more for our brothers and sisters from other African countries who participate in that meeting. So hopefully see you in October, where we will discuss lots and lots of topics on fetal medicine. We'll try to cover as much ground as possible. It will be a 2-day Congress, Monday, Saturday, and Sunday. It will be a virtual Congress. We're hoping next year we'll have a physical one. Let's see how things go. But thank you so much. And to the team that was doing the work behind the scene, the Fetal Medicine Foundation team, thank you so much. The Fetal Medicine unit teams, thank you so much. And the Fetal Clinic team, thank you so much for the job well done. And yeah, otherwise, see you guys around, those who are around here. And those who are outside the country will probably meet at the World Congress in June this year in Spain. So let's all go to the World Congress, those who can. So yeah, otherwise, have a good Saturday and bye-bye.